Okay, good morning, everyone. Thank you for joining us today. This is the Alzheimer's Disease and Related Disorders Advisory Committee. Today is Thursday, November 7th, 2024, and we are meeting both in person here at the California Department of Aging's offices at 2880 Gateway Oaks here in Sacramento. And we also are virtual here via Zoom. My name is Carol DeAndres, and I am the Stakeholder and Public Engagement Manager for the Master Plan for Aging. Thank you very much for everyone here. And you can see we have ASL. Thank you, Bailey, and Rex is his partner. We have Zoom closed captioning available to you via the webinar functions. And also you have a phone access should you need that. Let's do the next slide, Rosie. I'm Carol DeAndres. Welcome. Next slide. Yes, the meeting slides, transcript, and recording will be posted following this meeting on the Cal HHS Alzheimer's Disease and Related Disorder webpage. Next slide, please. The chat function is enabled only for committee members and Department of Aging staff and other guests to share out information with our public viewers, I should say. We invite the public to provide comments. We will have two public comment periods, one at approximately 11:50 a.m. and the second at 1:30. So please see the agenda for specifics on that. And of course, you can send public comments at any time to the engaged email box at engage@aging.ca.gov. Next slide. We will go over to the public comment mechanism once we get there, but we do have, if you are appearing in person in our offices, you will let Callie know, and verbal comments, you will press the raised hand icon on your Zoom functions or *9 on your phone pad. And of course, written comments at any time, either using the Zoom Q&A function or email engage@aging.ca.gov. Next slide. So Catherine, let me spotlight you. You can just hold one moment. I will bring Catherine up. And of course, I can't find Catherine at this moment in time.
It's okay. I am here and I'm not saying anything significant. So I just want to welcome.
Absolutely. Here's Ad Spotlight. Thank you for your patience. Good morning, Catherine.
Good morning, everyone. Welcome. I'm so grateful for all of you that can attend. We're going to have a presentation shortly from Kim McCoy-Wade. I just wanted to check with her to make sure she didn't need to start before 10:15.
I am fine, Catherine. Thank you so much.
Okay, excellent. So what we're going to do just very quickly is just ask our members to introduce themselves, and I will just say your name and which category you're representing on our advisory committee. And so Carlos, let's start with you. You are in the room. Thanks for being in person.
Hi, I'm Carlos Olivas. I am the caregiver advocate.
Terrific. Thank you. Welcome. And then I don't see, oh no, there is Dolores. Good morning, Dolores. Do you want to introduce yourself?
Yes, good morning. I'm Dolores Gallagher Thompson, and I'm the scientific representative. I'm a researcher and faculty member at Stanford.
Terrific. I don't see Ken Graffio yet, and Dr. Mobley.
Hi, Bill Mobley from UC San Diego, also a scientist and an academic physician.
Terrific. Barbara.
Barbara McClendon, and I am holding the seat for a community-based service delivery organization.
Wonderful. Thank you. Claire, welcome.
Good morning, everybody. Claire Day from the Alzheimer's Association, and I'm representing a consumer organization representing persons with Alzheimer's.
Wonderful. Thank you. Welcome. Wynn.
Good morning, Wen Canio. I'm a geriatrician and a psychiatrist here in the North Bay, mental health representative for this committee.
She's also our amazing vice chair, so grateful for that. Sally.
Was that Sally or Callie?
That was Sally. I will not be calling on Callie, so.
Good morning. I am Sally Bergman. I am an elder law attorney.
Thank you. Myra. I think you're on mute, Myra. Can you unmute yourself? Thanks so much. For me, it's at the bottom of my Zoom screen and it's a little thing under audio. Did you maybe find that?
Okay.
Look at that success.
All right. Excellent. I'm Myra Garcia. I live in Upland, California, and I am living with the disease.
So great to have you. Thanks for joining us.
Thank you.
Julie.
Morning. I'm Julie Soulier. I'm an assistant secretary at the California Health and Human Services Agency. And so I'm here representing agency. Thank you.
Wonderful. Thanks so much. Todd.
Yeah, good morning, everybody. My name is Todd Shutter. I'm the Chief Operating Officer for Active Care Living. We're in the residential care provider category based in San Diego County, and we provide dementia care and also serve residents from the regional center in 4 of our communities.
Thank you. And I just want to note that Celine Regalia isn't able to attend, nor is Dr. Farias, but we do have with us today Dr. Jason Gravano, who is just sitting in for Sally. So welcome. He's not a voting member, but we certainly welcome any comments you have during the meeting. And just as a reminder, one of the Begley-Keene requirements is that you leave your camera on if you're a member of the commission during the commission meeting. So we look forward to seeing all your smiling faces throughout the meeting. And I'm Catherine Blakemore, and I am serving as a family member representative on the advisory committee. With that, I want to just quickly have people look at the August meeting minutes and see if you have any corrections or comments to those. And if not, we can have a motion to approve those.
I move to approve.
Thank you, Sally. Is there a second?
I'll second.
Who was making the second? I'm sorry.
Todd, second.
Thank you. Sorry. Sometimes it's hard to see when whose light goes on. All right, there's a motion and a second. Any other questions or discussions? And we can do a roll. Do we need to do a roll call vote, or we can just do a vote? Just a vote. I think that's what we've done. Okay, all in favor, say aye. Aye.
Aye.
Aye.
Any noes? Opposition? Any abstentions? Okay, the minutes are approved and we are on schedule and even a little bit early. It is really my pleasure to welcome Kim McCoy-Wade, who is a senior advisor to the governor on aging and disability issues, and just a truly valued colleague of mine and so many people in both of our communities. So we're so grateful that you took time out of your schedule to be with us, and look forward to hearing what you say. For those of you that might not remember, Kim was one of the masterminds behind the Aging Master Plan, and continues really to help with the implementation of that in her position. So just lots of experience, and there's a bio that is posted that you can read all of the other details about Kim. So thank you and welcome.
Thank you. Genuinely, I am so glad to be in community with all of you today, to see Catherine said the bright smiles, but also, the shining stars that Vice President Kamala Harris talked about are so important to look at and gather together and be together. I want to bring you up to date and just take a step back and look at all that you and we have done together this year. In fact, the governor was poised to release the proclamation of Alzheimer's Awareness Month this week, but our press plan is a little different this week. But there is a proclamation that will go out this month for Alzheimer's Awareness Month. It gave us a chance to step back and say, where are we? Where, with the advisory committee, with the leadership by agency, Maria Shriver, the governor, and we're very pleased. And again, largely thanks to your continued engagement and advice, that all 10 of the bold recommendations from the Alzheimer's Task Force are launched, are underway. Whether the Take on Alzheimer's campaign this spring, the dementia aware training for medical professionals, Alzheimer's Day Centers, research on disparities, the first ever Alzheimer's Research Conference. That work was catalytic, and it was like the master plan because it wasn't a report that sat on a shelf. And the reason it wasn't is because of the teamwork between our agency leadership and all of you. So thank you for asking every time, where are we? What's the latest? What are the challenges? How can we solve? Because we can say, the governor promised that in his first State of the State, and 5 years later, we have delivered. The second thing I'm really excited about is the package of bills that got signed this year in partnership with the legislature, released on World Alzheimer's Day. No small part. One of those is requiring training for law enforcement in wandering and eloping, often seen in people with dementia. Yes, exactly. And that was very helpful to have your discussion in the summer with law enforcement and other experts in the field. That was very, very helpful to have had that advice from you all on that bill. Other bills requiring geriatric and dementia training for certified medical professionals, licensed medical professionals who have a high percentage of older adults. And frankly, increase outcomes and core services by our local aging networks, which will only increase our dementia information and referrals and connections. So it was a big year for implementation of administrative actions and continued progress on the bills. So know today, if you didn't already, that you and we are making a difference in people's lives. There is, of course, the broader picture of so much hope, both that rates are going down, even as the population ages and the numbers go up, we are bending the curve on dementia. And what's happening with our globally leading research partners, whether it's in treatments or cures or disparities or detection, is just happening so fast. I don't know who can keep up. I heard another story on NPR this morning. So it's truly a hopeful time for this disease. So then my question for you all, and it might be hard to have all the answers today and this week, is what are we going to do the next 2 years? What's our big, bold, audacious vision that actually touches people's lives? We already know we're going to help people have an easier time getting information as we kind of finally launch our aging information and assistance hubs, to be named, so that people know where to call to begin their connection to local services. We already know that more low-income folks are going to have help with home care, respite care, as we continue to expand Medi-Cal's paying for home care. We had a candidate who proposed Medicare at home. We're not there yet nationally, but in California, we are there with Medi-Cal at home continuing to grow. Super excited as we also celebrate National Family Caregiving Month, that paid family leave in California, where we have led nationally, will begin to have a higher wage replacement, helping more working families and low-income families afford to take paid family leave. That happens this year in implementation. And the question for you all is, what else? Where will you focus your time, your talents, to help us in the administration? As I already thought it was going to be a hectic race to the finish for Governor Newsom with his 2-year priority list that was hundreds long. That list is now growing and changing. And what do we want to have on that in this space? So Mainly today, I'm again grateful to be with you, thankful for your partnership and leadership. You will be hearing from the governor on both Alzheimer's and on family caregiving at some point this month, as we all take it day by day, hour by hour. But these are priorities for him and the first partner. I'll be weighing in on family caregiving as well. And we just want to stay in good touch, keep the hope, keep the leadership, the partnership, and have more to celebrate next year in the final year of the Newsom administration. So keep me posted. I try to come whenever I can. I always get energy and information and strategy from you all, and just echo in a month of gratitude. That's where we'll end up this month, in a day of Thanksgiving. Just want to express mine and the governor and the first partners thanks for all of you. Thank you, Catherine.
If you have a couple of minutes, Kim, if someone had a question or a comment, are you up for that? So anyone have comments for Kim or information that they would like her to share with the governor about the important issues that she raised? Dr. Mobley, please go ahead.
Yeah, hi, Tim. Kim, thank you very much for your comments. I'd like everybody in the committee to read a book called Being Mortal by Atul Gawande, in which he looks at the way that our geriatric system evolved, points to the real dearth of training in geriatrics, defines major gaps in the way we've built our, assisted living and skilled nursing facilities, and how the model has really been a medical model rather than a social model.
Mm-hmm.
And one thing I could imagine doing in the next year is to really explore in California, what are the gaps that we have? Not just in kind of the surface level, we need to provide more services for families. Of course we do. But maybe a more thoroughgoing, more, if you will, incisive look at caring for elders and the elderly in California, because the book is really illuminating. It tells stories about older people, how they changed over time, and how it was not always clear that the decisions they were being asked to make by family members were always the decisions that they wished to make. So I would really recommend that book to you, and think about that a little bit. I think this committee I can even imagine sponsoring a kind of working group to look at what is the status of the care of the elderly in California. And of course, it relates to Alzheimer's disease, because that's one of the principal reasons that people require medical care. Just a suggestion. And
I want to, there's so many parts of that, but I'll just focus on two that I think, one of the conversations, I hope many of you were able to attend the wonderful day of action that CDA convened last month. I think I heard from a lot of quarters assisted living has not been something that we have yet really focused on coming out of the master plan. And that is where, particularly as nursing home population continues to drop, more people, including many with dementia, are in assisted living. And we don't necessarily have a vision and a strategy for the diversity of that, the affordability of that, the location of that. Obviously, CDSS license it. But Claire, the other Claire, Sites Claire Day, has some great thinking, and I think so does Leading Age. But I think there is an opportunity to really think about what is the future of assisted living for those who choose that at times. The other thing I'll say I'm very much focused on is we're about to begin to make historic investments in behavioral health workforce. Those begin July 1st. And so what does behavioral health after 50 mean? Obviously there's some psychiatric and geriatric, but also what could it mean for community health workers? What could it mean for basic training for CNAs? I mean, you can imagine. So I think those are two opportunities that are ways that it would be great if this committee said, well, what does a behavioral health workforce mean for people with Alzheimer's? What does assisted living mean for people with dementia and their families? So yes, yes, and yes.
So I think it's such a nice discussion, because at the end of our meeting, we always go back to our discussions and say, what do we want to take on in the year ahead? And we almost always pull out a big part of our meeting to have those discussions. So really some good advice, I think, about good suggestion from Dr. Mobley and good advice about like, think about these things and what role we can play in moving that agenda forward. Todd, you had a comment, I think.
Yeah, thank you. I just want to tag on to what Dr. Mobley said. I agree 100%. It's a great book. I have read that. That's guided a lot of our development at Active Care, and we are really a hybrid off of assisted living and focus on caring for folks with some form of dementia in a purpose-built community. But the other piece that we have been fortunate enough to get into is we are now caring for folks with intellectual and developmental disabilities and dementia. And many of them are trapped in the wrong environment. They're in the regional system program, which is great. It's really unique to California to have 21 regional centers. But the resources and the infrastructure with where these folks are living is out of date and antiquated. And so getting them to a place where they can thrive and live longer, because those numbers are just swelling immensely, folks that have Down syndrome and dementia. We've had 41 of those folks live with us in the last 18 months, and it's been transformational, not only for them, but for us, for our staff. And I think there's really a newfound marriage with being able to direct people to the right and appropriate environment and let them thrive. And that population, as everybody knows, is just swelling like the geriatric population. It's really going to grow in the next 10, 20 years. And I'm not sure any of us are prepared for the numbers that are coming down the line for all levels of care, the healthcare system, assisted living, skilled nursing, acute hospitals. And so we really need to think about how we're going to get prepared.
Yeah,
So,
go ahead, Catherine.
No, you go ahead, please.
I really appreciate continuing to raise that connection. We've made a few of those, and the topic is around the rise of people with Down syndrome in particular, who are at higher risk for early onset dementia. And I think, the investments in the adult day centers and the Take on Alzheimer's campaign, to a certain extent, both included, obviously, people with Down syndrome getting daycare and getting day center care, and then also this awareness. The real I'm going to talk about the opportunities is the master plan for developmental disabilities, which Catherine in her other hat gets to work on. So we get to talk about both these things. Is a real opportunity to kind of reset the system, not only on performance outcomes and equitable outcomes, but also the changing nature of the population. One of the topics that has come up a lot is the key transitions. We've been almost exclusively focused on early start with IDD and less so on, I call it transitional age youth, kind of 16 to 26, what happens in that gap. And then 40 plus, 50 plus, pick your number, but the aging plan, particularly as families age and change as well. So I am looking to the master plan for developmental disabilities to include a focus on aging and a focus on dementia. Interesting to think about, Catherine, whether this committee should make recommendations or write a letter but
no, I was just going to say, so the transition work you talked about is actually the work group I have the pleasure of facilitating. And at our next meeting, which is December 19th from 11 to 2, sorry, we are actually talking about all of these transitions. And we've already done some work on transition age youth, and we'll do some work on early start to school. But one of the things on our list is individuals who are aging and where are we now, but where do we need to be? And so anyone that's interested in participating, there's always a public comment period. Or if you want to talk separately to me about sort of what you see as gaps, or if the committee wants to write a letter about it, that all of that's fine, but really on our radar about what can we do better in that space. So be a great opportunity for connections.
And just one other, I think the notion of time to think creatively, my understanding is the first housing in Berkeley just opened this last month. I think it's called the Gilman, that has 12 units. It's affordable housing, but 12 units are dedicated to people with IDD. And they are not segregated. They are throughout the building, and the regional center had a piece of it. So I have not been to visit yet. But if we can, I think that kind of thinking about ways we can use the marriage of systems to create these different is really the time is well, we're
Is
late,
that-
but let's do it now.
is that senior housing then? The Gilman House is senior housing, or
I don't think so. I think it's
just
just
regular housing?
we all need to go on a field trip.
We will. That'd be great. Okay, I think we have time for one more question, and I think that Carlos might have his hand up in the room. So perfect. Go ahead, Carlos.
Can you hear me? I just wanted to reiterate Dr. Mobley's recommendation for that book, Being Mortal. Because of me being a caregiver, it has opened my eyes to what can be adjusted and adapted. I think it's very impactful for caregivers to learn and read about that information that's in that book because it can support us in a way that we can also interact with community and understand that there is hope in grief and in transition of life.
That's great, Carlos. Thank you. I'm going to have to add this to my list. I'm very inspired to go read this book. So thank you, Kim, for joining us. If you could pass on to the governor that we're so grateful he signed the bill relative to this commission. And for me, it was so important to recognize that people living with dementia can be full and equal participants in our meeting. And that's sort of what came to being around the extension of their terms to be co-equal with everyone. So just grateful for that and the opportunity to add some additional members. So really, that's just sort of directly related to us and wanted to express our appreciation.
Absolutely. Absolutely.
Okay. Thanks again for joining us.
Thank you. Thank you. Keep up the great work. I'll look forward to seeing you soon.
Take care. Bye. Okay, we are now going to turn to our longest segment during the day, which is a really important topic about opportunities to embed dementia care navigation in California's No Wrong Doors system. There are so many acronyms. It took me a while to decipher the title of this. Anyway, DCN and NWD, sort of, it's very, very made me smile. But you can see the importance of that also to the Department of Aging and to the governor's office, because they're talking about how do we most efficiently get people information, caregivers, and support them during their journey. So I'm really happy to welcome our presenters, which include Claire Day, Jezebel Gavin, Mark Beckley, and Dr. Canio, who are going to do the presentation. I'm guessing that you're doing it in the order on the agenda, but if you want to mix it up, that is just fine with me. So, and their bios are all in the materials that you have, and I think just a bit ago there was a link posted to those materials. Okay, so take it away. Maybe Claire, you're starting.
I think I am starting, and I think you're sharing my slides, not me, right?
The slides are up.
Okay.
Correct. We are sharing your slides, Claire. Thank you.
All right. Well, thank you so much for inviting the Alzheimer's Association in particular to present a little piece of this big conversation, which we've all been talking about for so long, and this understanding this need for care navigation at all levels of care. And this was the results of a study that is part of our the Alzheimer's Association's annual Facts and Figures report in 2025. We did a special report. There's always a special report in this particular year. And I said 2025, but I mean 2024. I'm already jumping ahead on understanding the needs of care navigation. And we know that dementia care is complex. It's a complex maze. It encompasses interactions with primary care, with providers, with specialists, those involved in managing chronic care, as well as coexisting and cognitive issues. And that also has to include social service agencies and medication management, caregiver support. And so really what we've learned is, we all know the needs. We know there's more than almost 7 million Americans living with Alzheimer's 65 and older. We know that the cost of care is absolutely unsustainable, reaching about $360 billion. And we know that deaths are going to continue to be on the rise. We're an aging nation. And so this was really an opportunity for us to encompass what needs to be a growing trend in pulling together navigation as opposed to sort of a free-for-all. So you can switch to the next slide, please. And I did include just a couple of level setting slides. Of course, we know the burden of Alzheimer's disease in particular and other types of dementia are similar. We know that the disease process begins 20 years before we actually see any of the dementia symptoms. We know that age is our biggest risk factor. And we know that approximately at the age of 80, 75% of people with Alzheimer's dementia live in a nursing home compared to only 4% of the general population at age 80. And of course, this long duration of the disease contributes to this need to think about Alzheimer's and dementia as a public health initiative and as how it impacts our public health system. Next slide, please. And again, just as a level setting, we know the burden of caregivers. And Carlos, I'm always so delighted to see you at these meetings, but also raising your hand and using your voice to share the important needs of Alzheimer's and dementia caregivers. And we know that the value of the cost of care that they're providing would be about $350 billion in that unpaid care that family members provide. And how do we keep up with that care as family dynamics continue to change and as families don't stay together in the same cities anymore? It really just all points to the need for thinking about navigating this disease in a different way. Next slide, please. So that is how we came up with our need to map a better future for dementia care navigation. Next slide, please. So what we did for this special report was conducted 2 nationwide surveys, and you can see here with more than 1,500 and 1,200 dementia caregivers, family caregivers, and then healthcare workers. Who were most likely to provide care navigation services. So these were largely nurses, social community health workers. The survey of dementia caregivers included responses from the Asian, Black, Hispanic, Native, and White Americans. And you can see here that the survey examined several issues, including their experience, their exposure and attitudes on dementia care navigation. So really, do we understand what that means? What those services and supports could look like or that are needed? What are the perceived benefits of a dementia care navigation program for both people living with dementia and for family caregivers? And barriers, what are some of those potential barriers to care navigation? Next slide, please. What we learned from the dementia caregiver survey is that dementia caregivers want and need help navigating the current healthcare system. I don't think that's probably a surprise to anybody in this room. 70%, in fact, say that coordination is stressful, is managing all of these different elements of care. And while this was just looking at healthcare systems in particular, we know that that expands to community-based services and the need for in-community-based coordination as well. The cost of care and care coordination are top stressors for dementia caregivers, and the vast majority of dementia caregivers, 97%, say having navigation support would help. And more than 4 in 5 dementia caregivers, 85%, say having access to care navigators would influence their choice of provider. Next slide, please. And so what did we learn from healthcare worker surveys? 60% of workers surveyed say that current healthcare systems are not effectively helping people living with dementia. And it's because of this next this next data point, right? That there is no clearly defined process for care coordination and clinical pathways in healthcare systems for people with mild cognitive impairment, Alzheimer's disease, and other dementia. About 46% say these systems aren't, they don't have a process to how to manage this. And while many of these workers are helping to address these needs, they're doing it without any sort of formal pathway or formal training. Next slide, please. We also saw that dementia caregivers express difficulty and stress interacting with their healthcare system and addressing their own needs in this system. A majority of caregivers surveyed, about 70%, indicated that coordinating care is stressful. And more than half, about 53%, said that navigating the healthcare systems for persons they care for are difficult. So finding resources and support for their need is also a challenge for 2 out of 3 caregivers. Next slide, please. And as you can imagine, and I know this is a little bit hard to see, but you can see some of the anticipated outcomes of what a navigation path could look like, starting from none, which you can see there is very low, looking all the way up to improvement in quality of daily life, overall health improvement, improvement in health, less depression, longer period of time living at home. And we're thinking of, as we think about the importance of this in all communities, not just health systems, fewer behavioral symptoms, fewer emergency room visits, fewer hospitalizations and illness. Next slide, please. Similarly, we see anticipated outcomes for receiving those dementia caregivers receiving care navigation, anything from that low end of none all the way up to that high end of reducing the stress of caregiver, giving more peace of mind, helping caregivers be a better caregiver, helping them be a better caregiver, improving their own mental health. I mean, we talk about the need to take care of caregivers all the time, allowing time to take a break, making caregiving less time consuming and improving physical health, as well as improving, making caregiving less expensive. Next slide. Again, just some really good information here on what those navigation services are viewed as being most helpful. And you can see here when we think about the programs that we're piloting in California, very much in line with some of those care coordinated efforts between different specialties, helplines, access to someone 24 hours a day, understanding insurance and public benefit system, help with scheduling appointments, training on how to care for someone with thinking or memory problems, behavioral symptoms, and then understanding the overall system. Next slide, please. And again, thinking of what was most valuable in supporting dementia care for patients and their family, thinking about how to get that connection to those local services that are really going to be able to help support throughout the longevity of this disease, training, managing behavioral symptoms, all really high up on those needs, going all the way down to some of those help with understanding the symptoms, screening for safety needs, and monitoring medications, which I know we'll talk a little bit about later today. Next slide, please. Healthcare workers pointed to a lack of community-based resources for dementia caregiver and that current payment models don't incentivize care coordination as some of the greatest barrier to care navigation. More than 3 in 4 of the healthcare workers surveyed, which was about 77%, identified a lack of community-based resources as a barrier, and 44% viewed it as its greatest barrier. 7 in 10 called out restrictions in reimbursement as a barrier, with 41% saying this was the greatest barrier. Interestingly, healthcare workers did not identify workforce shortages as a top limitation of dementia care navigation. Next slide, please. And then for professionals who help dementia care patients navigate the healthcare system, survey respondents overwhelmingly agreed that non-medical professionals are best suited to provide these navigation services. Within their organizations, those surveyed reported that social workers, community health workers, and home health aides are often formally involved in care navigation, and 9 in 10 reported that these individuals are really best suited to help in these situations. And the final slide, just to review, I think this is just such an important topic. It's such an important piece of what we're doing, and certainly can provide more information on the full report if people are interested in it.
Just saying thank you so much. Really grateful for all the information that you provided. And I think that takes us to our next presenter, who is Jezebel Galvin or Galvin. Jezebel, welcome. I see you down there, and we can't wait to hear your presentation. Thanks so much for being here.
Good morning, everyone. It's so nice being with you all today. Can you guys hear me?
I can hear you perfectly. Thank you.
Yeah, and I'm just here today to share a little bit of my story, my family story, my father's story. You guys can see up in the picture. It's quite a little, like, from the statistics we were looking. My dad actually has early onset Alzheimer's. He just turned 62 last month, but he did start showing signs of the disease when he was 55 years old. And there were maybe like things that we would consider at the time simple, but my dad was a truck driver, and his dispatch person, they had switched from and they went like all electronic. So my dad didn't know a lot about that. So I went in to learn how to do his timesheet. And at the time I thought he had made a mistake with his timesheet. And when I went in and to talk to his dispatcher, he told me my dad was making very important mistakes, mistakes that he shouldn't be doing, especially being a truck driver for over 20 years. These mistakes including like going in the freeway on the opposite direction, driving a semi truck. So it was very concerning. So at home, he started also doing little things, like he would put like the milk in the closet, things that we would even laugh at or dismiss and say like, oh, he's really tired. Until hearing his employer's concerns, I decided to seek medical help. And when I took him in, his doctor kind of dismissed the situation and told us he just needed to rest more. So I reported this back to his employer, and instead of working 7 days a week at that time, they put him to work 5 days a week. And he was just getting worse. Nothing was really changing. So I went back and asked if he can be seen by a neurologist. And the first appointment they had for him was 10 months out. And seeing him get worse and worse every day, we just couldn't wait for that, honestly. So I kept insisting, and what they did is they got us in so he can get some psychiatric help. And the first diagnosis we got for my dad at 55 was that he had schizophrenia, which didn't sound right at the time, but being the naive young girl I was, I didn't question it much. And we started giving him the medication that they gave us for him, and he just got so much worse. He became like really violent, which my dad never was. And I kept like trying to insist, see if we can see the neurologist sooner, which they told us that wasn't an option. So that's when my family and I decided to take him to Mexico and see what we can get over there. And over there, we got a quick diagnosis. They told us off the bat, your dad has dementia. We didn't get his early onset diagnosis until way later. But when they told us that information, until that point in my life, I was very interested in maternal health, so I didn't really know what to do with this information. And not only that, we got this diagnosis in Mexico, so I didn't realize what a struggle it would be coming back to the States and getting the help we needed here. It was very difficult. We came back home, and my dad, since he was starting to forget things very oftenly, he would often take more medication than he should. So there was one point where his bottle was nearly empty, and we didn't know if he had taken them or not. It was a moment of a lot of confusion for our family. So I decided to take him to the emergency room at Sutter Hospital, and the doctor laughed at my face when I told him what his diagnosis was. His exact response was, at 55, And he looked at me sarcastically and laughed. And it was so frustrating because I didn't know what to do, honestly, at that point. And I think when I was leaving, one of the workers there saw me so like desperate, and she gave me a little flyer for PACE program at Sutter Health. And that was the first step we did, like just desperately trying to get answers. And they informed us it sounded great, like that we would get a nurse, they would answer all our questions, they would offer some education for my family and I about the disease so we can get informed. But none of that really happened. When my dad was in the program, I was at work one day trusting he was in a good place, and they called me. And my dad, he was at the point of his disease where he loved to wander. He couldn't stay still. So they called and told me that he was going to be arrested, and I was so confused. And they told me the reason was because he couldn't stay still, and they asked him multiple times, and he was getting frustrated and he started swinging at them. So I just couldn't believe that that was happening. So I became really upset. We took him out of the program, but again, we didn't know what the next steps were. Um, I think this just goes back to like the importance. If I would have had just one person like kind of guiding me, I turned to Google. That wasn't very helpful. But I do feel like after that, I was simply at the right place at the right time. I was actually at the grocery store, and the lady in front of me paying, when she took out her wallet, she dropped a card of the Alzheimer's Association. And then I picked it up for her, and it just caught my eye. And I asked her about it, and she told me that they helped her out so much with her mom, who was like 93 at the time. And I told her, I was like, well, I was even kind of scared because I got so many people like laughing at me. I was like, my dad's 58, but do you think he was like 58 at the time? Do you think they can help? And they're like, absolutely. So I called and I got so many answers. They helped me get my dad on disability, which had been really hard for my family and I because he was our main breadwinner. We couldn't afford to stop working and fully take care of him, but he also needed full-time attention. So we were stuck. And so they were able to get him on disability, and my mom actually, they helped us go through the IHSS process. But these were things I would have never been able to do on my own or figure out. And this just really got me thinking, I was talking to Michelle about this. If I wouldn't have been at the right place at the right time, I don't know what would have been to my dad. I probably would have never heard of the Alzheimer's Association. From there, I actually decided to pursue my education, continue my education to help out my community more. I got my master's in public health, and I feel so lucky. Sarah, actually, I think she's here. She came in to talk about CDA, and I didn't even know that was a thing either. And I was amazed. I knew I was like, I need to be an intern there. I need to learn more, and that's what I did. And that also helped me so much. It opened so many doors for me. From there, I was able to communicate with all the people I needed to get my dad the help. But again, I think about all the people in the community who don't have someone to advocate for them. And not only that, but I think so much about the delivery, how people in my community would even know about these things. So I think that's also like a very important component. People shouldn't have to be in the right place at the right time. There should be more help available, um, especially from like medical providers. And I hearing everything, I really hope like that does change.
What a powerful story. Thank you so much for being here. I really, it makes me cry and both also just feel kind of proud of you and your
I
journey.
think this is the first time I say it without crying, but I'm a little teary-eyed.
Yeah, but I think we should do a PSA with you to point out why people need services. That's just quite remarkable. So thank you for everything that you're
Absolutely. Thank you for
doing.
listening to me.
All right, I'm going to break our protocol. Todd raised his hand and says he has to say something. So, and turn up your volume. We couldn't actually hear you all that well last time, if you don't mind.
Should be a little bit better now. I turned it up. So Jezebel, thank you for sharing that story, because this is how, breakthroughs are made. But I also want to tell you, sadly, you're not alone. There's a lot of people that get caught in the healthcare system, whether it's a Sutter system or a Kaiser system. We all are working on and really do need to do a better job of educating people in the emergency rooms at the primary care physician level. And there is help out there. Alzheimer's Association is a great place to start. There's people just like you, a caregiver support group. If you're not in one with your family, that's the next step.
Yeah, we actually just joined. So
good. And I'm glad you're on your way. You will be a great advocate, not only for your family, but for other people with this horrible disease. So congratulations, you're
Thank you. I
really an
appreciate
advocate.
you so much.
Thank you.
So thanks, Todd. And thanks again, Jezebel, for joining. And we hope you'll just stay for the rest of the panel.
Yeah,
And
I
there's
will. Thank you.
other questions I'm sure that will come up. So next we have the pleasure of welcoming Mark Beckley, who is the Chief Deputy Director at CDA. And he is going to talk to us about state government efforts related to the No Wrong Door. So welcome and thank you.
Right. Thank you so much, Catherine. And it's so good to see Jezebel again. She, as she mentioned, interned for us, and really thank you for sharing your story as well, Jezebel. Yeah, so I will be talking about the No Wrong Door system, and I think the slides were just being brought up.
They
Great.
were, and then
Thank you,
they
Rose.
temporarily went away, but they're going to be right back. Here they are.
Excellent. Well, terrific. And thank you for having me today. Yeah, I'd like to describe our Aging and Disability No Wrong Door system. Just by way of background, the No Wrong Door system, when the MPA was being developed back in 2019 and 2020, this was one of the key highlighted, and rightfully so. The system, as you're well aware, for long-term services and supports is incredibly fragmented. It's really a true patchwork of services that can be very challenging for people to navigate. You know, if you need, say, 5 different services, you might be going to 5 different agencies. And not only will you be going to 5 different agencies, but you yourself will have to do research to figure out who those agencies are, what their contact information is, and what information you need to use to apply for those services. So what we're really trying to accomplish with the Aging and Disability No Wrong Door system is to really create a one-stop shop, a single solution that will help people navigate information about different services and supports that could be helpful to them, as well as having a human component as well. So actual professional navigators who can help someone decide what services and supports they might need. In its simplest form, the No Wrong Door system really consists of 2 elements. One would be a web portal, or you can just think of it as a website that has a provider directory of providers in your area that could provide different services and supports to you. And then some sort of a contact solution, which could be a single contact center, or it could be a federated contact solution where you can actually talk to somebody to help you navigate services. Next slide. Okay, this is the mission statement, which basically just states what I just said. But I would say the other key component of our mission statement is that a No Wrong Door system is a partnership between state agencies, between local agencies, and between local providers as well. So it's really a collaborative effort. And for this system to really work properly, there has to be strong communication and relationships among all three of those service entities. All right, next slide. Great. So here's the key elements of a No Wrong Door system. The first is a governance structure. And we were very fortunate 2 years ago to receive a grant from the Administration of Community Living for us to establish what we call the No Wrong Door System State Leadership Council. So this State Leadership Council consists of 5 state entities that provide or oversee direct services to older adults, persons with disabilities, and caregivers. Currently, those agencies are ourselves, so CDA, the Department of Rehabilitation, who co-leads the Aging and Disability No Wrong Door system with us, the Department of Developmental Services, the Department of Social Services, and the Department of Healthcare Services. In addition to those entities, the other key state partners would include partners within and outside of our agency. So you could think of, housing, transportation, employment, and the No Wrong Door system would expand over time to really encompass any service or support an older adult, a person with a disability, or a caregiver might need. And then, of course, our local partners. So the partners that we most directly work with our local area agencies on aging, as well as independent living centers. And then, of course, it's the local providers. It could be nonprofits at the local level who provide direct services. So this could be like Meals on Wheels, for instance, home delivered meals, local legal aid providers, family caregiving providers such as the caregiving resource centers. Again, any service or support that our populations might need. Person-centered navigation and referral process, which I mentioned. This would be professionally trained navigators. So people who are trained on proper intake, options counseling, and just navigation services, and then creating standard referral processes so that when we do handoffs to other providers, they're familiar with our system, they're ready to catch that referral, and we know the information they need to really fulfill a customer's request. And then the data and technology, so the infrastructure that really underlies all of this. I mentioned the web portal. Initially we're looking to stand up kind of a static provider directory, something along the lines of the website that 211 or Find Help or Unitas, those kind of platforms that those agencies use. But we also intend to create what we call an enterprise client relationship management system. So someone can enter in their information, it can tailor the search request to meet their specific needs, or that information would go to, say, a AAA or to independent living center to really tailor and customize the kind of options counseling that they would give to a client. And all of that information would be retained in the database. So if somebody calls back, then you'd have their information that you could just readily pull up or share with other providers. And then the contact solution that I mentioned. Some states have a single contact center that somebody would call, and that person would do all the options counseling for them and then refer them to local providers. Some use a federated solution with their local area agencies on aging, which each area agency on aging, depending on where someone lives, would catch the request, and then they would provide the navigation services. Next slide. Okay. I really like this graphic a lot because, they say a picture tells a million words or whatever. This really kind of shows in a nutshell what the No Wrong Door system is and how the process flow would work. So on the far left side, it starts with either the clients themselves reaching out through our web portal or through our contact solution, or it could be, community providers, professional caregivers, hospitals, health plan, other LTSS providers using this to help their clients. There'd be a standard intake that would be voluntary. If somebody wished to complete the intake, again, we could customize and tailor the services that we offer based on what they identify as their needs and what their preferences might be. And then that intake would be handed off to a navigator that would then help customize those services, or it could really tailor the searches that they put into the provider directory. But the other key element of navigation would be the warm referrals. So rather than saying, here's a phone number you can contact, they would actually call the other agency on the customer's behalf and transfer them to that other entity just to, avoid additional work on the client's part. And then at the very end, if everything works successfully, the services are provided, and hopefully it meets the needs of the populations that we're serving. All right, next slide. So what this slide shows is really the types of local entities and providers that we'd be working with. So our local area agencies on aging would be a key partner. We work with them to deliver a variety of different services such as nutrition, caregiving, legal, case management, transportation services, independent living centers, which serve individuals with disabilities on a variety of similar needs. Our caregiving resource centers, which again is just so helpful to provide training, education, respite services to caregivers. And then housing, transportation, and just a variety of others. Like I say, the goal here is to include as many programs and agencies that serve our populations so that all of their needs are met in sort of like with one engagement. All right, next slide. Okay, and here's some benefits of building a no wrong door system. You kind of see from a client perspective how beneficial this would be. But to talk about that benefit as well as other benefits, having a trusted and comprehensive resource. There's some for-profit organizations that will provide directories like this, but typically they have relationships with providers, they prioritize providers. You're not really getting unbiased services through those providers. Easier access to services and information. Again, a one-stop shop rather than having to do a lot of shopping around yourself. And then if we're doing our job right, we are really navigating people towards the services that are going to best serve them. So we expect to see improved outcomes and satisfaction. From the service provider perspective, receiving referrals in a standard format and avoiding collecting information from a person, say a second or a third time, definitely streamlining the referral process. I mentioned that enterprise client relationship management system that would contain all of the customer's information. With that information, we could do analytics such as identifying where the needs and demands for services are for certain areas, where the gaps are, and then we could work to really help address and fill those gaps. And then, of course, better coordination among the provider community. In terms of the LTSS system, generally, some of the benefits that we see are the more effective and efficient use of resources. Again, if you can eliminate the redundancy of collecting the same information from a client over and over again, that's clearly an efficiency. Potential cost avoidance. So the more that we can promote LTSS and HCBS services and keep people out of institutional care, one, definitely better for the individual. And then, of course, it can also help save on things like state, Medicaid costs and things like that. And then the ability to scale services based on the data we collect, we identify the needs, then we know where we need to grow our programs and maybe where the demand might not be so high. All right, next slide. And then these are some initiatives that are helping support our development of a no wrong door system. We do have an initiative that's specifically called out in the master plan for aging to develop a no wrong door system. So that just shows the commitment that we continue to have under the master plan for aging for the system. And then, of course, as we build out our system, we'll be engaging with the MPA work groups and advisory boards to make sure that, we are truly creating a comprehensive system. Our CA 2030 initiative, which is targeted specifically to strengthen our local area agencies on aging. One component of CA 2030 is to ensure that all AAAs are skilled in providing enhanced information assistance. So that's the standard intake, options counseling, referral processes, navigation, that they're all fully skilled and trained on providing that service. ADRC expansion. So we have a program which is a collaboration between the AAAs and the independent living centers to provide 4 core services, which includes enhanced information assistance to our customers. So we would look to grow that system to provide infrastructure for the no wrong door system. And then I mentioned the infrastructure that we're looking to develop: the web portal, a contact solution, an enterprise client relationship management system, and a data repository where we could do a lot of analytics. In addition to that, we would look to promote the system through enhanced marketing and outreach, and then build out other components of the system. Next slide. And then this is just a summary of current accomplishments to date. So as I mentioned, we did establish the State Leadership Council with 5 state agencies. We have developed an aging resource guide, which our comms department just did. I'm sure you've seen it, a phenomenal job with. We're going to expand that aging resource guide to also include services for individuals with disabilities. And then you're probably also well aware of the home and community based service gap analysis that's currently underway by DHCS and CDA. That will help us identify needs and gaps that will inform how we build out our no wrong door system. And then finally, creating what I mentioned, that online navigable resource directory. In its initial stages, it will be static. You can navigate it. You can put in a search term of the service that you need, as well as like your zip code, and it'll pull up a listing of providers. In the next phase of that, you could actually put in a referral that would be caught by like a AAA or an ILC to help serve you more through that person-centered navigation. And that is that's my presentation. And as relates to, Alzheimer's, obviously that's another, we would want to promote services and supports for caregivers and individuals with Alzheimer's through our No Wrong Door system as well.
Thank you so much, Mark. So much information in that short
Yes.
what you presented, and also just progress in advancing the No Wrong Door approach. So grateful for that. And we hope you and all the other presenters will stay around for a bit. So people have questions, we can do that at the end. That's great. Our last presenter is our vice chair, Dr. Canio, and it's about piloting dementia care navigation in No Wrong Door through the CalZ Connect. There are more acronyms in that sentence than I can imagine, but I am sure Wynn will inform us all what is going on. So thank you, and thanks for providing the information on this.
All right. Well, thank you. Thanks to Michelle, actually, for providing these slides and talking points to update us on the CalZ Connect pilot. And this pilot could be a model for the state as they build out their No Wrong Door effort that Mark just shared. So go ahead and go to the next slide, please. Oh, so the objectives of the pilot is to create and sustain a dementia-capable home and community-based services system for people living with Alzheimer's disease and related conditions and their caregivers using a no wrong door approach. And it ensures access to comprehensive, sustainable set of quality services that are dementia-capable and provide innovative services to people living with dementia and their caregivers. This is funded by the cooperative agreement to California Department of Aging by Administration for Community Living Alzheimer's Disease Program Initiative grant for state entities from 2022 to 2025. Go ahead and go to the next slide. Okay, so as I mentioned, we are using an evidence-based approach in developing the proposal. A CDA team actually looked at evidence-based model and selected the Care Ecosystem program, which was developed by UCSF. And this program was selected because of a couple of things. The support is provided by telephone, more accessible in rural and remote areas, and helps reduce barriers to access for marginalized groups, such as transportations or language access. Comparatively low intervention, since it's it actually uses allied health professionals instead of licensed personnel. And this helps to address California's current workforce issues and the mounting financial pressures on all payers to manage the growing population of people living with dementia. And as we look at the projected demand, its practical application makes it more scalable and replicable statewide. The other part of this program is Home Meds, which was also incorporated as developed by partners in Care Foundation. It's an evidence-based tool for identifying potential patient medication-related hazards. It's actually offered to both the person with dementia and caregivers. As we know, often caregivers have their own medical issues as well. It involves pharmacist consult and recommendations where system flags potential issues. It's important for us since our program is not based in a healthcare system. So that's the added benefit of that. Go ahead and go to the next slide. So how does this look like? So I'll spend a couple of minutes providing a little background on Care Ecosystem for those who may not be familiar with it. As mentioned, Care Ecosystem evidence-based model, it was developed by the UCSF, which involves a multidisciplinary team, and we'll have us focus on the diagram on the right there. That includes the dyad, and that is the person living with dementia and caregiver. And then as we know, who's the caregiver or paid staff supports a person living with dementia and is willing to participate in the program. And then this has been shown to improve caregiver well-being and quality of life for a person living with dementia. It has also been shown to reduce ED visits, potentially inappropriate medication use, and total cost of care based in Medicare claims. And then the other diagram, or the diagram, it says the care team navigator. So we build rapport with a dyad, learn more about their situation, including their stories, value, preferences, resources, and living situation. Help them personalize care to actively support the dyad and empower caregivers to be an advocate for the person living with dementia. They provide support linkages to community-based resources on advanced care planning and care coordination. And this care team navigator is actually our community health worker. For the clinical team, are individuals with dementia expertise and typically involves nursing and social work and pharmacy. This multidisciplinary team meets frequently with the care team navigator, as mentioned, the community health worker and the community health worker to discuss cases and are available for consultation outside of the meetings. And then the community resources are the teams continually update and expand shared resources for vetted caregiver educational information curated by both UCSF and partners and local databases for referrals. And of course, the healthcare providers for sites based in a health system, close connection to healthcare providers. In community-based model, our community health workers encourage dyads to reach out to the healthcare providers as needed. So what kind of topics are discussed during, stay there. The protocols include like immediate needs, COVID-19 disasters and related events, medication reconciliation and review, safety screen and recommendations, resources, referrals and education, caregiver well-being, behavior management, and advanced planning. It's a lot. Okay, and then go ahead and go to the next slide. For home meds, so how does it work? It identify and prevents medication-related problems, improve medication use based on a collaborative approach, and a medication inventory is collected by the community health workers, actually. Home meds assessment software algorithms generate the alerts, and the consultant pharmacist reviews all alerts and creates report with recommendations. And then the community health workers follow up with the clients and encourage them to share with their healthcare providers. And we will be sharing some initial data later on in the presentation. Okay. Now go to the next slide. And I'll talk about who's involved in this project. So CDA grant recipient. Each of these pilot county agencies serves older adults and people with disabilities through designated or developing aging and disability resource connection, ADRC programs. And CDA selected these sites for the strength of their existing programs and for geographic diversity, representing Northern, Central, and Southern California, including rural communities. In choosing the counties, we looked at factors such as size and diversity of older adult population, prevalence of Alzheimer's, and older adults who were Medicare eligible. So you can see that for Imperial County, it's the ninth highest Alzheimer's prevalence of any county in the nation. By utilizing the Aging and Disability Resource Center connection programs, this approach will provide streamlined access to dementia care information and supports within a community hub that offers resource navigation, assistance, and care planning. If ineligible for this program, staff can direct them to the other programs resources in the community. Since the program is based in a community organization versus a health system, we contracted with partners to provide the clinical support team. And then we use the Geiges group to help with the evaluation. Go ahead, go to the next slide. So why community health workers? For our project, we chose to hire community health workers to serve as dementia care navigators. They are the frontline public health workers. They're a trusted member and they have a close understanding of the community. They serve as a link to facilitate access to services, improve quality and cultural competence of service delivery, and builds capacity of individuals and community. And skills, roles, and competencies of community health workers fit very well with those care team navigators and the care ecosystem model. It's more commonly used in term in many communities than the community team, care team navigators. And Medi-Cal and Medicare both have a benefit now for community health workers as care navigators. Go ahead and go to the next slide. All right. And so now the implementations, the implementation started in October 2023. We're currently running in Marin and Ventura. Imperial had some administrative delays, but is currently training their community health workers. Some outreach built into the agency's ongoing efforts, along with targeted contacts to potentially referring agencies. So for community health workers, currently they are serving 52 dyads. As mentioned, that is the person living with dementia and their care partner. They conduct regular calls to assess needs and provide education, make referrals, and follow up on whether needs have been met using the care ecosystem protocols and resource materials. We collect information for home med reconciliation with the pharmacist consult and for project evaluation. And then they also create and update care plans as needed. Okay, go to the next slide. So when people are first enrolled in the program, the community health workers ask them what types of help might be useful. And you can see the slide here. It goes from, what is dementia and what to expect, 94%, how to cope with the stress of caregiving, coping with stress of caregiving, 83%, strategies to help person with dementia do as much as they can, 70%, caregiving support services and information, 64%, recreational or purposeful activity ideas, 64%, safety risk advice, 47%, managing behavior symptoms ideas, 47%, medication advice, 34%, programs to help pay for support services information, 34%, med legal or financial planning information, 19%, and backup or crisis planning, 13%. So this really shows what percentage of enrollees thought they might be interested in this type of support, and it really helps focus the discussion when these conversations happen, and then it's adjusted as needed when situations change. All right, so go ahead and go to the next slide. So just to give us an example, what kind of things are offered here, connecting dyads with community connecting dyads with additional community resources. So one example is supporting a woman who has been separated from her husband for 15 years, but has moved back in with him and his adult children to help care for him after his dementia diagnosis. And community health workers who are able to help get them connected to adult day health center and in-home supportive services so that she doesn't have to provide all of their care. And they receive meal deliveries, but they had a tiny refrigerator that wouldn't hold all the food, and community health workers were able to help them get a bigger refrigerator. So community health workers had a hard time reaching her sometimes, but her phone would be disconnected, help her get a free low-cost cell phone, and provided communication tips to the family and other education to help their interaction with the person with dementia. As far as providing tips for caregivers to improve quality of life. So another example here is discussing the benefit of daily routines and activities with another caregiver. Wife who was caring for her husband. Wife called back to let a community health workers know that she'd set up routine and they'd go and play ping pong every day. And the husband has gotten used to the routine and is getting to ask when they're going to play. They both enjoyed the activity and the routine help. And then lastly, support in communicating with healthcare providers. So an example for this, an issue with caregiver's father receiving a new prescription for an antipsychotic based on behavior during a hospital stay, concern about whether prescription was needed and impact it had on him when he was back home. So the completed home meds medication reconciliation I mentioned, done coaching around how to talk with a healthcare provider, also provided education and tips on how to address problematic behavior expression. Go ahead and go to the next slide. So there's ongoing monitoring for this. The clinical support is weekly. We initially conducted 2 trainings with the referral staff from each agency. The first training were on overview on the ADRD to make sure all had a baseline level knowledge and training on the program and referral process. The project team meets monthly and the steering committee meets quarterly. Evaluation and reporting will be shared in the next few slides. So one of the, let's see, so that you can see here, one of the things that were measured is the caregiver burden, and the Zurich burden interview was used, and an example of the questions that's there, it includes, do you feel that your relative currently affects your relationships with other members or friends in a negative way? And then the responses are never, rarely, sometimes, quite frequently. The higher score means greater caregiver distress or burden. And as you can see here, so far with our current pilot, we've had 16 responses and an improvement from a 35.4 to a 14.6 post evaluation. This was a comparison from 6 months starting the program and then afterwards. And then go ahead and go to the next slide. So in addition to the caregiver burden, another thing that was measured was quality of life. And again, one of the sample questions, how would Mary describe their current relationship with their friends? There were 13 questions that can be asked of a person with dementia or of the caregiver about the person with dementia. For this project, we also need to ensure that the same person can answer both pre and post survey. The higher the score, the better the person's quality of life. And you can see here with the initial data, there's an improvement from 32.6 to a 39.1. And I think that is it. Go ahead and go to the next slide. There's additional information for the CALS Connect, including the care ecosystem training that will be, I think, sent to all of us here, or it's probably already on the chat already. I think that's it.
Thank you so much, Wynn. So much information from all of you. Really appreciate the thought that's gone into all of these projects. So we're now at the time where committee members have the opportunity to ask questions or add something that we should discuss at a future meeting. So interested in hearing from any of you. Go ahead, Barbara.
This is a question for Mark. Is there a place in the state where you feel like the no wrong door system is more able to be accessed by the community, where you can really touch and feel it and it's working for people?
Yeah, I'm what we're trying to do, kind of like one of the building blocks of a no wrong door system would be our aging and disability resource connections. Like I mentioned previously, th we've just started expanding those over the past 5 years significantly. As a matter of fact, we had a huge accomplishment with LA forming a regional collaborative. And those are, some of them are places where you can actually go in to receive in-person counseling. By and large, a lot of their work is done over the phone with folks, and they do provide services like options counseling and enhanced INA. So I feel like that is one part where it's starting to emerge. But yeah, I'm hoping that when we do get this like single providers directory set up, which we're hoping to do over the next years, budget willing, that will really start opening people's eyes, and they'll really have that resource that they can tap into. Unfortunately, I think it'll be several years until we actually get to the web portal component where you can get referrals to AAAs. I think that's going to be tremendous when we eventually get there. But right now, I'd say ADRCs is probably where we're probably closest to it at this point in time.
Because Jezebel's comment about just getting lucky in the grocery store line with a card that fell out is just like continuing to be all too much the case for families,
Yeah.
and especially here in Los Angeles. I have a lot of concerns about how is this really going to be built out in such an integrated fashion that our families here in Los Angeles, which is such a difficult place to figure out up from down, that they're going to know it's there and connect to
Yeah.
it for services. So that's kind of one of the
Well, it's
things that
really
keeps me awake at night.
It's really like, it's sort of my question. What is an outreach strategy to ensure that this information is widely available, and given the state's focus on ensuring access to traditionally underserved communities that speak different languages and
Yeah.
have different life experiences, including immigrants who, are awful fearful of asking for services, right? So is there an outreach strategy? I mean, I ask that in part because I do this other work and people come up to me and say, oh, by the way, I have a family member with Alzheimer's. So I know you're not working on that right now. But how do I get help for them? So then, I
Right.
find the, the place they can go, and they're grateful. But again, it's kind of like they happened to see me and thought
Yeah.
I could help them, or a card fell out of a wallet. So I guess overall,
Yeah.
how is
And
outreach?
and that will be a struggle. I think, and in talking to other states, they've done pretty robust outreach strategies. It could be done through television, radio. It really depends on how much of a budget you have to conduct outreach. But, I'd say, we're really going to focus a lot on just in terms of like naming, branding, logos to make sure that it's something like we'd love to get to the point of where Covered California is, right? Everybody knows Covered California. They know what it is. They know what it does. If we're successful, we'd like to get to that level. Now, Covered California had a pretty robust marketing and outreach budget. So we'll have to see what our budget size is. But we want to make sure that the naming convention is really simple, like Aging and Disability Resource Center or something, just something really simple and catchy that resonates with people. Some of the terminology that we use just isn't that. What's a AAA, right? What's a Aging Disability Resource Connection, or ADRC? So we're really going to focus on that and hopefully come up with something that's simple, easy to remember, that people can just search and find pretty easily.
So I'll just make, like, I actually think looking at ways that you can effectively use social media, which will not cost anything close to the amount that radio, television, even if it's free, you have to, kind of pay to have the work done or find a way to get that done. And I've done some work on the access to justice side, where the way we were helping sort of test could people more easily find access to lawyers was doing these Facebook kinds of postings. So if you want information about that ever, let me know. And it just seems like starting someplace to help get the word out, branding completed or not, is going to help move this forward, because the goal, of course, is to get people accessing the services. So anyway.
Oh, that's great. No, we would love your ideas.
I
Our
will.
communication team will be taking this on, so I'll make sure to connect them with you when we
Yeah,
get
that'd be
started.
great. Feel free. Okay, Dr. Mobley, thanks for asking a question.
Yeah, thanks, guys. Really helpful. Let me ask the money question. Obviously, there's a fairly big investment in maintaining a navigation program. Is there an attempt, or has there been an attempt to show that this is cost effective for insurers, for families? I mean, is there an analysis, Mark or Claire or Wynn, that demonstrates that not only is this good for people, but it's also good for the cost of healthcare?
I think some research has been done in this space. We've been working with a vendor on this project called Collaborative Consulting, and they've looked at no wrong door systems that have been established elsewhere. And I can dig that up and see if I can share that with everyone.
It seems to me that Mark, that would be a really powerful way to sustain the program going forward, because this takes a lot of energy, a lot of people, and a lot of money, and showing that this really is not only a human benefit, but that there's a financial benefit to it. It seemed to me would be very important as, again, just sustaining it and maintaining it and making sure that it's as robust as it needs to be.
Yeah, absolutely. And it gets to that cost avoidance. So just from a practical side of things, if you're going to make an investment in a system like this, can you show offsetting savings, to like the healthcare system, for instance? Yeah, and I think that's the kind of business case we would want to develop.
So
Thanks.
perfect. We can think about some of these to say in our letter to our new secretary. So, Dr. Gravano, welcome.
Thank you. Mark, I was wondering, will your databases and interview assessments be available to the people that you're passing on the information to?
Ideally, yes. And I put kind of a caveat on that because, of course, we always have to look at HIPAA, we have to look at PHI, we have to look at eligible entities to receive or pass information along to. But I believe that by and large, the answer is going to be yes. We'll likely have to do, consent, get some sort of consent form from the individual to share the information. And if we receive that, then we would be sharing that.
Okay. And is it built around the current systems, data acquisition, like, the care centers, how they acquire information about their clients? So can it be shared in an easy way, or is it going to be another piece of paperwork for the people at that center to review?
Yeah. Ideally, it'll be an easy way, and that's where it gets to like the establishment of our enterprise client relationship management system. I think initially the AAAs are really going to be the hubs, and right now they're on 5 different systems. So we are going to try to get them all on one platform, and once they're on one standardized platform, then we can standardize the referral processes, work with our partner agencies and providers to show them what we plan on using, and try to get them to use something similar, so that you can have more of a seamless and standard process.
Great. And the last question I have is, I don't want to use the term loaded, but I know it has a lot of implications beyond the question itself. But is there any way to make this an opt-out system rather than an opt-in? Right now, it's people that are interested, that are searching, that are watching TV at that moment. Is there any way that we can have this be, you're going to get an inquiry and you can decline this type of more advanced care navigation?
Are you talking about like the intake form, for instance?
I'm talking about the process. This is a wrong door, which implies someone has to go through your door, right? They have to make the onus is still on the patient and the family, rather than the providers. I know you have the providers in that window, which is excellent, but it strikes me as that our assumption here is to still put the burden of asking for information or trying to seek out information on the person that are needing to be connected to these services, which is, cart before the horse in some ways. So is there any way that, it has been investigated or, in a big picture plan, when a diagnosis is made or when things
I see. From the
done,
provider perspective, could you require them to
an
use
automatic kind of like you're connected here and then you opt out of that system? I know there's a whole bunch of other issues there. I know there's a lot of other things, but is there any discussion of that?
Not at this point, and it's a really interesting question. We can see what our consulting firms research shows for other states, if they've attempted to make this, an opt-out system versus an opt-in system for like, provider organizations.
Great.
Yeah, and I could see, I definitely see the benefits. I also see, legal arguments against. But yeah, that's definitely something worth looking at.
So I think that's a really interesting suggestion. So grateful that you're gonna think about what that would look like and maybe
Yep.
how the provider gets consent to send the referral off, right? So the provider has a conversation and says, yes, the person wants navigation help, which might take care of one legal problem, like why did this person get arguably HIPAA protected information, right? So anyway, just my thought.
Right.
Blair.
Yeah, thank you, Catherine. And I just wanted to sort of answer to Dr. Mobley's question about cost analysis, right? And I think the other way we're starting to look at that is, I think we're going to learn from the guide model, which isn't exactly the same, but I think it will lend us to learn. I mean, it's a pilot, it's an 8-year pilot, but that's the intention, right? Is to find out whether or not there's a cost, what the costs are, and what the cost benefit could be. And how we get that reimbursed. So I think that the guide model will play really, really deeply into working in tandem with these types of programs.
Thanks for that. Other comments or questions from committee members? So I have another one while other people are thinking. In this concept of expanded navigation services, I think is what you're calling it. Is there a way for people to get like actual help completing applications, right? So you need to apply for disability benefits or you need to apply for IHSS services. And at least in my experience, the barriers for just finding time to go through all that paperwork are completely daunting when you're also doing caregiving. So is that an expanded service? Have you thought about that as an expanded service?
It could be. And again, in other states, there are no wrong door systems sometimes do help individuals complete certain types of applications. It would have to be an agreement with a partner agency. For instance, if someone is attempting to enroll in Medicaid, likely County Health wouldn't want to relinquish that. But, maybe we could do some sort of partnership where there's an easy handoff or for some programs, some partner agencies might be okay with us giving that type of application assistance. I mean, in an ideal no wrong door system, you'd have it. That would be the true no one-stop shop. If you're applying for these 5 different programs and there's certain, key information that you're going to ask across all applications, why not just have one person assist with that, right? And fill out as much of that application as they can. So yeah, I mean, that's ideal, but it would be a lot of coordination work with partner agencies to get their agreement.
Yeah, and I'll just flag like in the developmental services master plan in my work group, which is the only one I actually know a lot about, but one of our recommendations is for CHHS to develop a common application for services at least available through all the departments that serve people in CHHS. And there's such good models of how the data can be aggregated and used to essentially you put your data in once and the system helps you figure out like what you're eligible for, right? Anyway, so just flagging, like I
That's
think
great. Yeah.
some cutting edge things could actually help.
Yes. Yeah. And we'll follow along with that particular recommendation. I'll be interested to see where that goes.
Yeah, it will be. It clearly has cost. Okay, others, since I could talk all day long. Anybody else have comments? Such terrific, really terrific progress. Grateful for what all of you are doing and all of these diverse projects. And of course, share Barbara and Barbara's question about how do we make sure people actually know this exists. So maybe more to come about that. Okay, I think in Carlos, it looks like you have a comment. Thank you.
Yeah, as a family caregiver, I'm, this is like the first time I'm hearing about this dementia care navigation and this there's no wrong door. So I want to, emphasize that we need more of this. And we need to scream from the rooftops about this, because there's so many people out there that need support and they don't know where to go, and they need to be welcomed with open arms when they finally reach out and ask for help. And I don't know, we need to explore avenues where it's easier for people like myself to call a phone number or access it on the internet and feel that we are being seen and heard.
Yeah, thank you. And I hope you will also hold on to that comment as we're developing our recommendations at the end. I mean, there are things like a single phone number that routes you to the place you need to go based on the number you're calling from. A little complicated because we all have cell phones and they don't actually reflect where it might be, but it's just there's strategies we can all use to help get people more quickly to where they need to go. So thank you. Thank you, Carlos. Does any other member have any questions? So I want to just thank Claire and Jezebel and Mark and Wynn for putting together the materials and taking the time to inform us about all the work. And I'm going to guess that the committee will want you back to hear an update about how this is proceeding. And I see applause from Myra, so thanks for sharing that. I think what we're going to do is turn to a public comment session. We're a few minutes early, but we can do that. And I see Shella, who is a public member, has raised her hand. She raised her hand earlier where we weren't having public comment. So maybe Carol, I think you do here's how public comment works slides, and then we can take Shella's comment.
Yes. Hopefully we have the slides coming momentarily. We will put that up.
And if not, you can probably just start.
I can walk you through it. So we are
So
having our public comment period. Let me highlight our ASL interpreter. Go. All right, thank you. We are going into our public comment period. The public is encouraged to use the Zoom icon to raise their hand. Also, you may press *9 if you are on the phone. And I'd like to remind you, public comment is for 2 minutes, just so we make sure we hear from everyone. And I'm going to go ahead. And Shella, you have been unmuted. You may go ahead. There you go.
There we go. Okay. Hi, good morning, everybody. This has been a really interesting meeting. I'm so happy to participate. My name is Shella Komindu-Mong. I am the parent of Simone, who's 33 years old and has Down syndrome. And it's the reason that I am participating today. But I am also a member of the Master Plan for Developmental Services group, the Developmental Services Task Force. I participate on the Disability and Aging Community Living Advisory Committee for Housing Subcommittee. I'm an affordable and accessible housing advocate. And I have had concerns about my daughter and her functioning in the world since COVID. And, everything changed about her services, and we've had some signs and some symptoms. I was particularly interested in the 2-year plan that Kim McCoy-Wade spoke of, because we, for a while now, have been having trouble with accessing Alzheimer services, or even getting recommendations from our local regional center about how to identify if there's a problem, receiving any kind of assistance or referrals or authorizations for services for baseline testing. And Simone is on Medi-Cal, right? She's on the big DD waiver. I am involved in trying to do what I can in terms of housing policy in the state of California for people with developmental disabilities. And yet still, after all this time, her needs remain unmet, and there doesn't seem to be a process for us to log the unmet needs and then have them inform services. And so I just think as part of a 2-year plan that the state really needs to focus on making sure that developmental services can advise people. When I asked for information about Alzheimer dementia services or facilities or like what was happening, I literally was told that there was no recommendations for me, not only from her case manager, but from the adult team manager. So there's really like no plan of action in place, at least at my regional center, for when people come to their case manager with concerns about this aspect. And so it is also something that's not really being addressed in the master plan. And so I heard Kim talk about that developmental services and people with developmental disabilities were going to be a focus on aging and dementia and these transitions. Hopefully something coming out of the master plan process. But I think that if the state really wants that info, then they need to be specific with the people on the master plan about the information that they want, because the work groups in the master plan are not entitled and set up in your typical way. It's like, oh, what about, and then people on the master plan were sort of limited in the items that they could select. Like a work group had 3 priorities, and the system is big, the need is great, and it's sort of limiting. So the state has mentioned at several different junctions about the need for the master plan for developmental services. They're hoping that they're going to get some data or some info about key functions and like the gap analysis. I mean, that's not really happening anywhere. So I just wanted to bring these things to the forefront from the perspective of a parent, of someone who's not considered aging, but who is disabled, who has these needs, that cannot rely upon the services that we receive through the regional center system to address this need. And I'm hoping there's something that can happen. Thank you very much.
Thanks for
Thank
the
you,
public.
Shella.
Thank you. Okay, are there other public comments?
If you have any public comments, you may raise your hand at this time. Use your Zoom webinar functions. If you're on the phone, *9. Let me add our ASL interpreter in. There we go. And at any time, you may send an email to engage, ENGAGE, at aging.ca.gov. And we will have Callie put that again into the chat, so you can copy that. I am not seeing any more public comments. Catherine?
Okay, so I think what we will do is just take our break a little bit early and come back a little early. Does that work for everyone? Okay, and so why don't we plan on coming back? It's about 10 to 12, at about 12:20. or a minute after that will give us our 30 minutes. So thanks, everyone. Amazing part of the meeting. Thanks for the public comments. Look forward to seeing you in 30 minutes.
Back at 12:21. Thank you.
Thank you, Carol. Thank you so much. Welcome back, everyone, after a nice little break. And it is really my pleasure to introduce Sarah Steenhausen, who's going to give us the California Department of Aging update. And before she does that, I want to just take a moment to acknowledge all of her work on the Aging for All Day. It was absolutely spectacular, so much good information and so uplifting. So I know that was a lot of work, but thank you for doing that. And we look forward to hearing from you.
Well, thank you so much, Catherine. And I have to say, we have an incredible MPA team here led by Jackie Tompkins and Carol DeAndrea. So they really get the credit for it. But it was a group effort, and really want to appreciate all the work that the Alzheimer's and Related Disorders Advisory Committee put in to develop the key recommendations, to participate in the day, and to just really just move forward such productive conversations. I have loved today's meeting and the engagement from all of you. We always learn a lot from you. So thank you for that. Okay, so we are going to show some slides today. Let's see here. So I'm going to give you an update on kind of some key initiatives related to the Master Plan for Aging, in addition to some of those that you've already heard from our team today. Next slide, please. I am going to talk about, so what do we do now that we had the day of action? What are we doing with all of the information that we heard from stakeholders, and what are our next steps? Then I'm going to talk to you a bit about one of our key MPA initiatives, our long-term services and supports financing initiative. And then finally, I want to brief you about a new federal grant we received from the Administration for Community Living that really advances our caregiver work. Next slide, please. So as I said, we are just so appreciative of those of you who are able to attend either virtually or in person to the Day of Action. We had, I think a little 400 or so in person, and then over 600 participating online. It was just a wonderful time to re-engage and recommit to our work on the Master Plan for Aging. And we're approaching our, hard to believe, our 5th year of implementation. So the Day of Action really helped us to hear from all of our stakeholder advisory committees about the key priorities that we must consider as we work on developing the next iteration of the master plan that will be released in January. So if you want to go see any of the sessions, you can go to caforall.org, and you'll see the links to different sessions throughout the day. So I really appreciate the MPA philanthropic partners for supporting this event. It would not have happened without them. Next slide, please. So importantly, what are we doing with this? It's wonderful to get everybody together and to celebrate and to identify the most critical issues to address, but we have to actually be committed to doing something with it. So what we've done is, since the time of the Day of Action, we've compiled all the recommendations received from the committees. We also have compiled some additional recommendations that we hear about, we've heard, collected over the past few years. And then we're internally reviewing MPA draft initiatives with our state partners. So meetings with our Health and Human Service Agency Department colleagues, with other agencies like Business Consumer Services Housing Agency, the California State Transportation Agency, Labor and Workforce Development, Veterans Affairs, and others, and really kind of seeing what is feasible and what can we advance for the next 2 years. Simultaneously drafting and iterating on the MPA initiatives through December, and then getting buy-in and feedback from the governor's office, and then finally releasing the MPA initiatives in January of 2025, which is also when we will be releasing our annual report to the legislature. So again, all of this is to say that the work that you all do over these years is not just doesn't go into a vacuum. We really are using it to inform our understanding and how we can advance system change. And we also are very careful in setting expectations because, as you all know, there are a lot of considerations that we have to balance in our work with the state, significantly, resource issues. So we listen and we try and pursue bold system reform, knowing that we have to do our best to make it happen. And, it might be iterative and it might not be everything all at once, but we feel very confident and good about the progress that we've achieved to date. Next slide. So I want to talk to you a bit about, this is our framework for long-term services and support system change. Earlier today, you had a really incredible discussion about the no wrong door system, but also about this broader issue of how people navigate the system. This is one of our 4 key pillars of system change through the Master Plan for Aging. So once we develop a system that is more navigable, then we second have to think about access to services. So a lot of people say, well, that's great if you're developing a wonderful streamlined information system, but then if you don't have programs to send people to, or if those programs have lack of capacity, what good is a streamlined navigation system? So as part of our access efforts, Mark Beckley mentioned this, but we are carrying out a statewide home and community-based services gap analysis and roadmap initiative. This is being done across both the Medi-Cal home and community-based services delivery system and the non-Medi-Cal home and community-based services. So this crosses departments, and it also is going to include housing and transportation, because we recognize that access is not just about the social services, but it's also about housing and transportation. It really doesn't mean anything if you don't have a place to live or a way to get to where you need to be. The Department of Healthcare Services is leading on the Medi-Cal gap, the Medi-Cal gap analysis, and CDA is leading on the non-Medi-Cal component in partnership with our other state department partners. We anticipate having the gap analysis released for our non-Medi-Cal gap analysis will probably be later next spring or early summer. And the Department of Healthcare Services is on track to release theirs probably sometime early 2025. After that time, we will work on building a roadmap for how we build capacity in the system and address the gaps that we identify in the gap analysis. The third bucket that we're focusing on, third bucket is at the bottom of the screen, workforce. So even if we've built out access in the system and we have it more navigable, it doesn't do anything if we don't have the workforce to support it. So this is a key goal of the Master Plan for Aging, is supporting and uplifting and retaining our workforce and growing our workforce to meet the needs of our aging population. So we have a number of initiatives underway, trainings, incentive programs, and building the workforce pipeline. We're doing this, not only in the Health and Human Services Agency and departments, but in partnership with the Labor and Workforce Development Agency. And then finally, the key pillar of system change in the LTSS system that we are trying to figure out how to address is that of financing. I know this committee has talked a lot about the tremendous challenge that people who are not eligible for Medi-Cal and fall in that group of people, which is often called the missing middle or the forgotten middle, where they don't have significant resources to self-fund their own long-term services and supports needs, and they yet are not eligible for Medi-Cal. So they end up depleting a lot of their income and going on to Medi-Cal and impoverishing themselves. That is not an ideal system. That is not how I think anyone would have designed the system. So I'm going to talk to you a bit right now about what we're doing in this area of long-term services and supports financing and what the next steps are. Next slide, please. So next slide. So the problem, I touched on it, but basically older adults, people with disabilities, and caregivers are really struggling to pay for long-term services and supports. Many people assume Medicare is going to pay for it and then are shocked to find out that no, Medicare does not pay for the non-medical functional support needs that people need to remain at home and in the community and get the services that they need to live with dignity. So what we are doing is we're embarking on an initiative to research some of the best practices, define our target population of who we need to solve for, and identify the policy opportunities for the state to move forward with. Next slide, please. So we were really fortunate to receive $5 million in general fund resources through the Budget Act of 2022. And essentially, it calls on the Department of Aging to conduct research and analysis to develop policy options for improving long-term services and supports financing and affordability, all in line with the Master Plan for Aging. So I'm going to talk to you a bit about what this initiative looks like. Next slide. So we have been really fortunate we have an incredible group of contractors and subcontractors that we're working with for a multi-component initiative. First, to define and analyze the target population, their profile, and their needs. Second, to explore the potential for what Medicare can do in this space and really building a business case for how Medicare, not Medi-Cal, can invest in home and community-based services and have it actually prove the business, the return on investment for addressing the functional needs that people have. Third is developing policy solutions for this missing middle population. And then finally, delivering a final report to the legislature in June of 2026. And all throughout, we are engaging state leadership, consumers, and stakeholders in this work. And I'm going to talk to you a bit about what it looks like. Next slide, please. I want to talk to you a bit about our work on the Medicare space. We are really fortunate that we have partnered with ATI Advisory and with the LTSS Leading Age LTSS Center at UMass Boston, led by Dr. Mark Cohen, who is really a preeminent researcher on LTSS financing. But essentially, ATI Advisory was able to look at all of the Medicare fee-for-service claims data in the state and look at what percentage of Medicare enrollees fall in the kind of high functional, needing functional support. The people who have mid to late level frailty are about 20% of Medicare enrollees. And what this research found too was that the 20% of these Medicare enrollees account for 50% of Medicare spending and 67% of ER, hospital, and post-acute spending. Why this is so important is because we are using this data to show that if you invest in functional needs and functional supports of the Medicare population, you can actually avoid some expenditures on the Medicare acute, ER, and post-acute spending side. So again, this is all part of this narrative that Medicare does not pay for functional long-term services and supports needs. But if we can prove that actually the federal government could save resources by providing maybe a limited home and community-based services benefit, then there might be a business case for the federal government to want to take this on. Next slide, please. So in addition to that work on this Medicare demonstration, which we have developed the program concept in partnership with ATI Advisory. We're also doing an actuarial analysis of the model with Milliman Actuaries, and we're going to be done with that, I think, by the end of the year. And we have had early conversations with the Center for Medicare and Medicaid Innovation, but things have changed a bit at the federal level, so it's not clear exactly how that conversation will continue. But regardless, it is our intention to release all of this and release the Medicare draft proposal for a pilot project that would test the delivery of home and community-based services in Medicare, what that could look like, and what the actuarial analysis of it. Even if California doesn't end up doing it, it would be very informative at the federal level and across states. But we're hopeful. We're going to maintain hope that we can do something like that here. Meanwhile, we have, through our contractors at LTSS Center at UMass Boston, also subcontracted with Urban Institute to do a population profile. And through something that they have called the DynaSim model, we are projecting out the needs of our aging population, what their LTSS needs are slated to look like, not only now, but into the future, so that we can really think about what it's going to look like at the state. At the same time, we are doing a comprehensive policy landscape analysis across states and best practices of where what we can learn from in terms of how other states have funded long-term services and supports, either through new public benefits for LTSS or through Medicaid expansion. We are also working with Community Catalyst and Collaborative Consulting to do a series of focus groups where we listen to consumers from across the states to understand what their needs are and how potential policy solutions would impact them. And then we're working with NORC at the University of Chicago to do a survey of California's Medicare beneficiaries to understand kind of on a more quantitative level what their needs and preferences are. And then with all of that, we are going to issue the final report in June of 2026. So that's a little focus on our LTSS financing initiative, which we're really excited to be underway with. Next slide.
And Sarah, I just want to flag you have like maybe 5 minutes left.
That's fine. I'm almost done. I'm going to
excellent. Thank you.
With a highlight of a new federal grant we just received from the Administration for Community Living. You heard earlier from Wynn about the CALS Connect program, which is seeking to develop a dementia-friendly no wrong door system. And there was an opportunity at ACL to apply for a grant to advance our caregiver work in line with the national strategy for caregiving. And we were able to build off a lot of our other work that we're doing, both in the workforce with our CalGrows program, but also through CALS Connect. And I'm going to tell you just high level what this grant is going to be doing. Next slide, please. Oh, well, this is just giving the context for the Master Plan for Aging, as well as the Alzheimer's prevention and preparedness work, where we are developing, testing, and scaling models to improve awareness, navigation, and education opportunities for caregivers. Next slide, please. The first goal is to increase awareness, and this aligns with National Strategy Goal 1. So we are working with U.S. International Media, USIM, partners to develop culturally and linguistically appropriate messaging to reach out to our diverse caregivers in the state. And then working with trusted local media, ethnic media partners to develop the messaging so that we can raise awareness among our caregiver population to help them identify as caregivers and to know where to go for support. Next slide. Our second goal is to build off this issue of navigation that we've been talking about today. So as you know, we're working at the state level to advance this no wrong door system, but we really wanted to understand how we can better engage caregivers earlier. And this falls a lot along the lines of what you were talking about with people falling through the cracks. And if it weren't for Jezebel's finding the card on the floor at the grocery store, she never would have known about the system. So what we're trying to do is actually map local referral pathways. We're going to have key informant interviews with caregivers and provider organizations, and we're going to have an analysis of those findings to help inform our work at the No Wrong Door System Change Initiative. Next slide, please. Third and finally, we're focusing on education. We've been fortunate with the CalGrows training program to develop a comprehensive inventory of training for both paid direct care workers and unpaid family caregivers. This was a $150 million initiative that is wrapping up now. We trained over 25,000 paid and unpaid caregivers, and we don't want to lose this great work. So we are working with our partners and including our partners at DDS to ensure that we have access to training using what we got from CalGrows. And we're going to be developing, kind of curating the resources and putting them in an accessible platform on our website moving forward, and disseminating all of the recommendations from that work. So that is kind of a summary of the 3 goal areas of CalCares. And right now we are just beginning to launch with our partners. You can see our partners here are the Department of Developmental Services, UCD, Family Caregiving Institute, USIM, Collaborative Consulting, Marin Center for Independent Living, Imperial County, and the County of Ventura. Next slide. So I just talked, we're also going to be looking into next steps of how we draft a steering committee. And if any of you are interested on sitting in the steering committee, please let us know. We're looking for participation from a number of our different advisory committees to see who might want to be part of this effort. So I will stop there if there's any time for questions, though I think I might have gone over.
How about if anybody has a burning question, please feel free to ask Sarah. I thought that was really a great report and helpful about the work you're doing on the long-term care benefit. So thanks so much. Questions? Okay, you were just so thorough and comprehensive.
All right, thank you all. Appreciate it.
Thanks so much, Sarah. Appreciate it. I think we are now, Wynn is going to move on with our California Department of Public Health update and lead that discussion with that staff. And I just wanted to say, by the way, Michelle Johnson, in case you were missing her today, although the meeting is going swimmingly without her, which is great, shows all the great preparation. She is at a national conference on Alzheimer's on the East Coast, I think. So that is why she's not here today. So we miss her, but I realized I didn't say why she wasn't here. So, okay, take it away, Wynn. Yep, there she is.
Hello, good afternoon. Now we have the Department of Public Health, Tina Fung, presenting Alzheimer's disease program update. Take it away.
Great, thank you, Dr. Canio, and thank you, Catherine. Good afternoon. My name is Tina Fung. I am the manager of the Alzheimer's disease program within the chronic disease control branch at the California Department of Public Health. I will be providing some updates on our most recent work within ADP. The next slide, please. So our program focuses on 3 different categories with different goals. We have prevention, clinical, and caregiving, as well as research and evaluation. So I'll start with our updates in our prevention pillar. In February of this year, ADP launched the Take on Alzheimer's public awareness media campaign to promote risk reduction, educate Californians about the science of Alzheimer's, and encourage conversations with loved ones and healthcare providers around screening. Our media vendor recently completed a tracking study survey to measure the campaign's effectiveness. From this survey, we learned that the campaign built Californians' awareness of Alzheimer's disease by generating over 297 million impressions on the Take on Alzheimer's campaign website via online paid media tactics and offline tactics. The campaign also generated over 874,000 website visits with an engagement rate of 45%. Our media vendor also completed a report on the campaign overall. We anticipate having that published early 2025. Next slide, please. ADP currently funds 13 local health jurisdictions throughout the California through the California Healthy Brain Initiative, or California HBI, to implement public health strategies that promote brain health, address dementia, and support people living with Alzheimer's disease or other dementias, or ADRD, and also their caregivers. The state project is modeled after the CDC Healthy Brain Initiative Roadmap. The project term will end this fiscal year, but our 13 counties continue to collect ADRD surveillance and program data on a semi-annual basis to inform their community activities and services and to ensure the California HBI metrics align with the CDC HBI. And concurrently, ADP is finalizing an evaluation report of the pilot cohort that worked on this initiative from 2020 to 2022, and we anticipate publishing that report by the end of this year. Next slide, please. In this fiscal year, 24-25, ADP was one of several CDPH programs that received a portion of the CDC's block grant that was awarded to California. ADP intends to use this grant to expand the California Healthy Brain Initiative work to include tribal and rural communities that are currently not funded to conduct HBI work. We plan to create and engage a community practice collaborative made up of tribal-led and tribal-serving organizations and rural health departments. And with the help of trusted partners, ADP will provide HBI resources, technical assistance, and training to tribal and rural communities. This work will be continuing until 2029 with the ultimate goal of expanding HBI work to under-reached communities and rural regions of the state. Next slide, please. And so next is our clinical and caregiving updates. All right, so ADP hosted its annual California Alzheimer's Disease Centers conference in September of this year. A total of 73 individuals attended, representing all 10 CADCs, which is also California Alzheimer's Disease Centers, the 13 HBI counties, ADP-funded research grantees, and state and local partners, including the Alzheimer's Association, Department of Healthcare Services, California Department of Aging, and then also Healthy Aging Initiative, which is a program within CDPH. The conference was the first time that all ADP-funded projects had an opportunity to connect and identify community and clinical linkages among CADCs and local health jurisdictions. And discussions were made to improve both the coordination of services and dementia health outcomes within their local communities. The conference also provided attendees with important legislative, clinical, local, and state updates to identify key priorities and strategically plan future work. Next slide, please. We are currently partnering with the University of California, San Francisco in Fresno and the University of California, Irvine to create a caregiver training and certification curriculum with the goal of creating 28 modules. This project aims to expand access to evidence-based dementia-related education and training for caregivers with a specific focus on unpaid family caregivers. To date, 28 modules have been developed and are in the process of being tested and piloted within local communities. The final videos and module guides should be completed in the beginning of 2025. Next slide, please. In addition, ADP implemented the Standards of Dementia Care Initiative with the goals of improving dementia screening by one, creating a tool for providers to identify patients, especially those populations who are underdiagnosed, who would benefit from earlier brain health screenings, expanding the dementia care aware work that the Department of Healthcare Services oversaw, and providing an online library of resources for providers, and reducing racial health disparities in ADRD screening and care. So one of the projects that is part of this initiative is the Brain Health Toolkit led by Dr. Deb Barnes from UCSF. Initially, this project was to implement an existing electronic risk calculator to identify patients at high risk for ADRD and have them screened. After some focus group testing on primary care physician needs and priorities, Dr. Barnes and her research team learned that a new electronic tool could overwhelm providers' workload and time. And they also learned that patients play such a tremendous role in initiating the conversation on Alzheimer's disease and other dementia screening with their doctors. So as a result, Dr. Barnes developed the Brain Health Toolkit, which takes a more patient-centered approach and builds patient empowerment, which also aligns with the California Surgeon General's current goals. Next slide, please. And now I'll move on to our research and evaluation updates. So over the summer, ADP launched its research symposium series to bring ADP partners together to listen, learn, and have open discussions on ADRD research to provide more opportunities for alignment and collaboration. The symposium sessions are hosted quarterly. The second session was held on October 18th, and the presenters included Dr. Michael Weiner. He's a professor of radiology at UCSF, and Dr. Rachel Noshaney, associate professor in residence at UCSF. They delivered a presentation highlighting the Alzheimer's disease neuroimaging initiative and the Brain Health Registry. Next slide, please. ADP also started updating the statistical report of ADRD in California. This is in partnership with Dr. Jarman Ye from UCSF. The initial report was published early 2021, which did not capture the effects of COVID-19 on ADRD diagnoses and death rates. The state is due for an updated report analyzing the impact of the pandemic and also continuing data collection of underrepresented and underdiagnosed populations. Next slide, please. And lastly, ADP is in the works of launching an evaluation project that assesses the government's task force recommendations. The purpose of this task force, as you may know, was to present recommendations to the governor on how local communities, private organizations, businesses, government, and families can prevent and prepare for the increased rates of Alzheimer's disease and all its outcomes, and to navigate a path forward to address the effects of Alzheimer's disease. The 10 recommendations were developed by the task force as a roadmap on how California can address Alzheimer's disease prevention, and it could be found in the Alzheimer's Prevention, Preparedness, and the Path Forward report. So we anticipate executing a contract for the 25-26 state fiscal year to evaluate the recommendations. Next slide, please. So I thank you for your time, and if you have any questions, please feel free to reach out to us at ADP within CDPH. Our shared inbox email address is alzheimersd@cdph.ca.gov.
Thanks so much for all the interesting information and progress you're making. And I think you're in a new position, so welcome to that. We're happy for you about that. And I'll ask if members of the committee have any questions since we have time. Barbara, it looks like you have a question.
I do. Hi, Tina. Nice to meet you. The state report that you noted is due for an update. Is there a timeline for when that will actually happen and that report be released?
We have started the analysis for the updated report, and we hope to have the analysis written and published by June of 2026, I believe.
Thank you.
Thank you, Barbara.
Other questions? Okay, I'm not seeing any, and thanks for providing how people can provide information or ask questions after the meeting. That was great. Oh, it looks like, sorry, I overlooked Carlos, who has a question. Go ahead, Carlos.
question about the caregiver training. How is that going to be pushed forward? Like, could I be a part of that since I'm a caregiver?
Yes, we'll have a more established caregiver training dissemination plan. Right now, we're in the works of disseminating through our partners at the CADCs and our HBI counties. But we will have additional information in the next advisory committee meeting on how you can access that information and training.
That's great. And it looks like Jason Gravano has his hand up.
Oh,
Hi,
Dr.
Tina.
Gravano, you can provide more information. Thank you.
I can. I'm a co-investigator on the project for the caregiver training. Our plan for the Northern California side is to host these modules online for free without any sort of sign up or other requirement. And so when the modules are finished with our partners, they'll go up on the website and everyone will have access to them. It's just about knowing when they're available. So as Tina had mentioned, once they're ready, we're going to try our best to make sure that the people, at the state level and as many providers we can kind of can get on board to start putting these out there as free, accessible resources. And these also will hopefully, what we're trying to do is make sure that they point not only to the trainings themselves, but to other available resources. So it kind of tries to collapse some of the complexity of navigating all this stuff yourself. So if you have a particular question, it can help point you in that direction. So ours will be hosted on a website. Right now, it'll be on Valley Caregiver Resource Center's website. It is not up there now. Don't bother looking yet, but we're working with the web host to start getting those up. We hope that we'll have initial versions of in English in January, as Tina had mentioned. Though, there's other barriers and technicalities for getting all of the languages that we're trying to work with up as well. So we're hoping for that timeline, and we'll make sure that everyone is updated with our progress.
So thanks for the nice update. That's great. Carlos, did you have any other comment about that?
Oh, just that. Thank you.
Yeah. And I think we have a meeting, I think in February-ish. So it would be great to get an update of if that has actually happened, because I think there's lots of people on this Zoom that would appreciate that information and opportunity. So really terrific news. Okay, other comments, questions? Okay, thanks both to Tina and Jason. We appreciate you making time for us, Tina and Jason. I think we get you for the rest of the meeting, so that'll be great. Thanks so much. Okay, we are going to turn to our ever important legislative update. We heard a little bit about that from Kim McCoy-Wade this morning from the administration's perspective, but we are so fortunate to have Eric Dowdy and Barbara McClendon here to give us their perspective of what's happened and maybe what still remains to be done in the legislative session that we will begin after January this year. So Eric, it looks like you're up first, and thanks again for being here.
Yes, thank you, Madam Chair. Welcome, or thank you for having me. I'm a little under the weather, so I'm going to try to plow through this as best as I can. So advance to the first slide, please.
And feel better. Hopefully.
Thank you. Next slide, please. So I will go over the 3 bills that we worked on the most here at the Alzheimer's Association. We sponsored 3 and got 3 signed this year, so it was a really great year for us. First bill was SB 639. This was by Senator Limon, dealing with medical professionals. It adds new training requirements to 3 different categories of medical providers. First, to physicians and primary care physicians, most importantly. It adds care of persons with dementia to the existing geriatric care requirement. That's new. And then also a new requirement for nurse practitioners and physician assistants. So the requirement, which is new for them as well, is a 20% of their continuing education must be in geriatric or dementia care, if the patient population for which they care for is 25% or more over the age of 65. So hopefully you can understand from all of those numbers what we're doing there. It's basically trying to target those healthcare providers who do have a significant portion of their population dealing with older adults, that they are devoting some of their continuing education to dementia and persons who need assistance with their care. So those become effective January 1st, 2025. Those will be handled through the respective medical boards. So you should see information coming through the California Medical Board and other boards under the Department of Consumer Affairs very shortly once those are rolled out. Next slide. There we go. AB 2680. This is the bill that affects this committee. So we did a lot of work around kind of getting this in a good position to make it easily go through I would say easily, but it made it through the Appropriations Committee, which has been kind of the barrier in the previous years. Most notably, you'll notice that the name of the committee will change. So it's now the Alzheimer's, well, I'll say as of January 1st, this committee will be renamed the Alzheimer's Disease and Related Conditions Advisory Committee. It adds a minimum of 2 up to 4 new members to the committee, up to a maximum of 20. It removes the stigmatizing language that's been in the statute. So things that have been mentioned as suffering from Alzheimer's, et cetera, we move that. We also remove the term limits for the members that are living with the diagnosis. And then also we've added the ex officio members. So those are members from the Assembly and the Senate appointed by the Rules Committees. And then also we're adding 4 additional members to be appointed by the HHS Secretary at her discretion. And then also another bill that was running in tandem with this was AB 2207. So that bill passed and now gets added to the statute. So it adds the executive director or his or her designee to from the Commission on Aging to the committee as well. So those are all going to affect January 1st. I know the Department of Aging will be handling all this, so we'll be watching for signs from them on kind of how the implementation will work. And the final slide, if we can move to the next one, is basically an extension of the California Alzheimer's Disease and Related Dementia Research Voluntary Tax Contribution Fund. Rolls off the tongue, so nice. That was due to expire, so we have extended that to 2032. I did want to note that the fund only stays around if it meets certain minimum contribution amounts. So if we ever dip under the $250,000 mark, the fund is repealed. So although it's established, through the next through 2032, it could go away if it's not utilized. So we do want to make sure that contributions are still made, and we should be talking about this, I think, a lot more than we do. So those are the 3 bills I was going to talk through. I know that Barbara is on to talk about a lot of other bills that impact the space, so I could turn it over to Barbara now and then hold questions to the end.
That sounds great. Thank you.
Thank you, Eric. Okay, next slide.
And
So
I
we'll
just want
start.
to acknowledge, can I just acknowledge that
Of course.
Susan Damaris has joined us, and we're just always happy to see her. So thanks for making time. I know you had a busy day. So go ahead, Barbara. Sorry.
Yeah, no worries at all. I'm going to start with a piece of legislation that was sponsored by my organization, Alzheimer's Los Angeles, in partnership with Alzheimer's Orange County and Alzheimer's San Diego. This was actually mentioned by Kim McCoy at the top of her comments. This is related to the Commission on Peace Officer Standards and Training. And they will be developing basically guidelines for law enforcement agencies to improve both response when someone wanders and how law enforcement can be in the community and more effectively working with families to actually prevent wandering before it even happens. So this bill becomes effective January 1st, 2025. We go to next slide. So the next bunch of bills, again, these are not specifically with my organization, but they're bills that I do think are important for our families to know about. These two are related to making the paid family leave program work better for everyone who can access that program. And I will say that I do feel like there's a lot of work to be done in this space to make people other than those who have just had a baby or adopted aware of the program and encouraging them to use the program, because it's a pretty small percentage of people that take advantage of the program who would be what we would think of as caring for someone who's living with Alzheimer's or another form of dementia. And then, as Kim McQuay had mentioned as well, the percentage of someone's pay that this would replace is actually increasing this year. So it's just really could be such a difference maker for families if they know that it's out there and they're encouraged to use it. So the first bill, SB 1090, relates to allowing people to apply for the benefits before they're going to go out on leave, just so that they're not when they're actively caring for the loved one. That's kind of the worst time to have to try to jump through the hoops of applying for the program. So this would allow them to do that proactively, but benefits would not begin until they were actually had taken the leave. And then the second bill is related to allowing people to access the paid family leave program without their employer being able to require them to use vacation time first. I will just note there was one other paid family leave bill that didn't pass that was related to family of choice. So that if you had someone who isn't in that long list of relatives, but is someone who functioned in your life in the same way that a family member would, that bill would have allowed that person to be able to access paid family leave. Unfortunately, didn't pass. I think that's, work to be done in going forward. Next. The next bill may seem like an odd one for me to be bringing up here, but we have had families calling our helpline. San Diego in particular has a lot of former military in their community, people who are gun owners and may be living with a dementia, and there are just some concerns around safe gun storage. This bill is not specific to people who are living with any kind of cognitive impairment. This is for all of us, and just requires safe gun storage in a very particular way. So it's not you've decided a shoebox is safe gun storage. There's actually guidelines on what that means. So this is something my organization, Alzheimer's Los Angeles, is looking just to make families aware of. Sometimes for family caregivers, a piece of legislation or some sort of formal requirement could just be a really excellent tool for them to have a conversation with their family member so that they can ensure that, they can provide care for them in ways that are safe. So I would, what that brings to mind to me are the requirements around driving. It can be really helpful for our family caregivers when they've got that physician who's kind of alongside them saying, hey, this is what I'm required to do to make this report. Let's just talk about how we can keep you safe. So I think of this safe gun storage law in kind of a similar way. Next slide. That's not my slide. We can go to the next one. Okay, great. Thank you. And then just a few budget items. So I hope you all are aware of the Ombudsman program and understand how absolutely critical it is for ensuring, I'm just going to keep talking. Okay. For ensuring safety and quality care for people living with cognitive impairment in facilities. And so this provided some funding from some specific special funds so that they could strengthen and expand the Ombudsman program. It is less than what they originally asked for. My understanding is they're planning to come back in this next legislative session to ask for those additional funds so that they can really truly meet the need in the program. Next slide. The next one related to the community-based adult services program. We don't have our representative from that program with us today, which is kind of too bad because I would have liked to have gotten her thoughts on this. So CBAS has just been in real dire need for rate increases so that these programs, which are so important for our families, remain financially viable and accessible. The reason I have a question about it is it looks like one of the ballot measures related to Medi-Cal funding is going to pass. And I think there's maybe some relationship between any rate increases that might happen for CBAS programs and the passage of that ballot measure. So I'm not exactly sure how that's going to end up playing out in 2025 and whether those rate increases will actually happen for CBAS. Next slide. So just a couple other slides that are about some of what was included in the budget. The processes that the governor puts out specifically. Well, there's a budget in January and then another one in May, the May revise, and then the legislature gets busy and they have to come to some agreements. And so there were a number of programs that had been slated for some cuts that did actually stay in the budget. And one of them is the Home Safe program, approving $50 million for the Housing and Disability Advocacy Program. And then also the final budget did continue to include in-home supportive services for undocumented Californians. There's one more slide, I think, on budget stuff. Yeah. So also we're so pleased to see that that the cuts that had originally been proposed for the APS systems expansion and training were rejected. And so funding was included in the budget for that. Again, our folks are so vulnerable when it comes to abuse and neglect. And so a strong, robust APS program is just really essential. And so we think that this expansion and training is so needed, and now it is able to go forward. The next item that's related to mostly nutrition money. And so that it continues to be there. Also, again, a very important program. There was an approval of some reduction of older adult behavioral health initiative and a media campaign to go along with that, though one of our earlier speakers talked about some work that is ongoing related to older adult behavioral health. It would be perhaps worth a focus in one of our future meetings on that topic. I know that this committee has discussed that over the years, and we might be due for a conversation on that again. There might be one more slide, or that's the last one. Okay, great. Thank you.
Thanks so much to both of you for all the good information and, more importantly, all the good work to get these items through the legislature. It's so, I find it impactful that this committee really had the opportunity to influence at least two of those. One, we just did the training last time about police interactions with individuals with dementia and wandering, etc. And now it's actually, as Barbara mentioned, it's now in statute, and Kim referenced our interest in that as something that was important. And then, of course, the changes to our committee, which I am really just thrilled about in terms of kind of the equality of terms and the change in names, and really just updating us to reflect how we currently think about Alzheimer's. So both very exciting, and they wouldn't have happened without both of you. So we're just incredibly grateful for your expertise. But with that, how about questions from committee members? Okay, I'm going to, this might be too technical, Barbara, but I think what you were talking about with the rates for the adult day healthcare centers relates to the proposition. I don't remember the numbers that said there had to be, if there's a tax, that was called a healthcare tax, I guess it's called, on medical providers, it could only be used for certain kinds of services, and that this service falls outside of that. Is that what's happening?
I think it's Prop 35, and the proposition just enumerated, this is my understanding, if someone else is here who knows this better than me, please speak up, but enumerated the services that would be would be included in the pool.
Mm-hmm.
And for whatever reason, community-based adult services was just not included in that pool. So I don't think anyone was saying that's not a healthcare cost. I don't know if Miss Lydias were with us today, she would know the backstory for why it wasn't included in that. But that is my understanding that with the passage of 35, while it ensures that that managed care or the MCO tax has to go to just these health expenses, I think there are some health related expenses that are going to fall outside the purview of Prop 35. And so previously negotiated rate increases for CBAS, I think could be impacted negatively. That might be something they need to go back to.
Discouraging because it's such a service, and maybe at the next meeting there'll be more information and kind of an approach of how that could be backfilled in some ways or whatever could happen. So thanks for the update. Things end up being complicated in ways that we might have.
It's so true. When we ask the general public to weigh in on these things, it's very, very difficult for everybody to really fully understand the picture there. So here's where we are.
Okay, thanks for that. And then when I spoke with Michelle about the changes to the commission, she said that she is looking at bylaws changes to add the additional members and clean up our language. And those, of course, will go through the CDA leadership. And if all that happens, then there may be something for us to look at our February meeting about that. So that would kind of put us, at the beginning of the time that the changes went into effect, which would be great. And then the committee would have the opportunity to give advice about what types of members to add for the remaining two, etc. So just wanted to acknowledge Michelle being on top of things as she usually is, and something to look forward to. So other people have questions or comments? Any forecasts for the next legislative session then? Anything you're looking at or we should be aware of, or?
Well, my understanding is, I hope I'm not jinxing anything just by even saying it, but my understanding is that tax receipts coming in are looking reasonably decent. So maybe we won't be looking at the kind of budget deficit that we dealt with last time. These things can change, but cautiously optimistic there. And then I think, as Kim alluded to going forward, and Sarah made a mention of it too in passing, the changes that are going to be happening in Washington I think are most certainly going to have a trickle down effect. And so we'll just have to see. We may be in a bit more of a reaction mode, trying to protect things, but we don't know that for sure. So, we will be watching and ready. Eric, I don't know if you have other thoughts.
I would concur on the budget. The budget is kind of looking a little better than predicted, but I would take that with a grain of salt. And everything else I know is rumor, and I wouldn't want to share it yet.
I think for those of you that don't like to multitask as much as I do, it looks like the governor called a special legislative session to be proactive about whatever changes there might be. And I always think it's worth looking at, are there any risk we're worried about for older adults that could be part of that legislative session in terms of protections, etc. So for those of you that do work in the legislature, I'm sure you're also thinking along the same lines. So with every challenge, there's opportunities, I suppose, particularly in California, where the administration has demonstrated its commitment to health and human services issues, for which we should all be grateful. Okay, I don't see any other comments, but thank you again so much for all of your work and the CDA staff's work within the administration to secure the positive outcomes that we just heard about that. And I think with that, we are going to move to public comment a few minutes early. And Wynn, I think you are going to do that in the last item. At some point, I need to go pick up grandchildren from school. That is my Thursday family obligation. So I will be signing off at some point, but it's been a great meeting and just so grateful to all of our presenters and the good information that was shared. I think we just had really some phenomenal presentations and lots of forward movement. So that is wonderful. So take it away, Wynn.
All right, Catherine, thank you. Yeah, we are now here for a public comment. Carol, are
Happy
you
to help.
able to? Thank you.
Thank you. Good afternoon. It is our afternoon public comment period. If any of our attendees would like to give a comment, you may use the raised hand icon in your Zoom functions. If you're on the phone, you may press *9. And of course, you may always leave comments, written comments to our Engage email box, which is engage@aging.ca.gov. So I will turn to our attendees, and I have Shella, who is wishes to give a comment. Do want to remind folks that we have a 2-minute time frame so that we can hear from everyone. So go ahead, Shella, you can unmute.
Good afternoon. What a great meeting. I attend a lot of meetings, and this one is so chock full of good information. It's a pleasure to attend. I noted that there was a lot of information, a lot of links in the chat. I tried to do a mass copy and, paste into a document so that I can access them later. And I'm just wondering whether or not there will be a follow-up email to participants that have all those links so we don't have to go one by one and, cut and paste and whatever.
I think that they certainly will be embedded into the presentation itself, and that will be posted, but I'm sure that we can do a comprehensive list if we can do that after the meeting.
Thank you all so much.
Okay. Have we any other comments? And of course, if you feel that you have a comment after the meeting ends, please send a written comment to our engaged email box. E as in elephant, N as in Nancy, G as in governor, aging.ca.gov. And Dr. Canio, I don't see any more hands.
All right. I think now it's the time for us to have our recommendations for the secretary. This has been a terrific meeting. We've discussed numerous issues that will really significantly improve the lives of people living with dementia and their caregivers in our state. So now it's our opportunity to raise some specific recommendations for our secretary. So I know we've been making recommendations along the way, but does anyone would like to add anything for our committee? No? Oh, Barbara.
Hi. So there were 2 other pieces of legislation that didn't make it out, and they were related to family caregiver or caregiver access to loved ones in a couple of different kinds of healthcare settings, so skilled nursing and hospitals. I know those were brought forward in the context of the pandemic, but even setting pandemic aside, it is an issue that members of our support groups have raised. And I know that Catherine in the past talked about that access, especially in the hospital setting, as maybe being an ADA issue, but I don't see any of our caregivers filing lawsuits. But I don't know, maybe that's not the way that you enforce that. Anyway, I would just maybe I know that the California Department of Aging had a whole work group that looked at that access and skilled nursing facilities, but I just kind of don't want the issue to just go away because those bills didn't pass. So I don't know if we could be something to the secretary about just drawing attention to the fact that those bills didn't pass, but yet the issue remains. And we would just like some attention to it.
Okay. I know Derek and I were in that committee a few years ago. Anyone else?
When I think my comment about just the importance of outreach, about the navigation services as a strategy that might be captured in the comments otherwise, but I think we spent time talking about that, so it would be great. I just wanted to highlight that as one of the things I hope we could include.
Agree. I don't see any other. Well, we've been talking about a lot of accomplishments and plans already, so I think I know someone has been taking great notes of all of our recommendations for the day.
When could I pop in one more?
Sure.
This is just building on all that fantastic discussion we had related to the no wrong door system and the aging and disability resource centers. If we, to make all that potential come to life, it's going to have to be funded appropriately too. And so if we could just put in some kind of comment about that, like we're not going to, nickel and dime our way to a really integrated, accessible, no wrong door system. It needs to be funded, robustly. In addition to the outreach campaign to make sure everybody knows it's there.
Yeah, for sure. All right.
That's part of the funding conundrum
Yep.
too, right? You can develop a system with the resources you have, but I absolutely support your reference to make this work. It has to be adequately funded, and that includes for the outreach part. Yeah.
And obviously these are actually two of our recommendations that we had made at the California Day of Action. So, all right, Jason.
Hi. I think I don't know if this is the proper forum for this, but the CDCs as hubs for diagnosis and education are underfunded and understaffed. And so when we talk about the capacity question through no wrong door and all these other things, I think it speaks really most poignantly by the testimony of a 10-month waiting list for a community neurologist. I know the CDCs are facing similar challenges and have not had a raise in funding since, I think, instantiation. So I don't know how that fits in, and I know I'm not a full-fledged member, but I just wanted to make sure I was in agreement with that observation that capacity is quite limited.
Thanks for that. We've raised that before, I think, and it's worth raising again. It was certainly one of the public comments today about the importance in the intersection of Down syndrome and dementia space, the importance of getting accurate diagnoses. So worthy of a mention again. So thanks for refreshing us.
And I hope we've had the Dementia Care Aware for the last couple of years. I know the funding just ended, but with the CME requirement now to raise the awareness of dementia diagnosis, and probably, if you're a primary care physician, having CME, being able to learn how to diagnose would be there, that will hopefully help with that. Claire?
Yeah, and the good news is that a bit of dementia care aware will continue, and so that training is still available.
Great. Any other recommendations for our secretary? All right. Well, now
Mobley had his hand raised. Sorry, when.
Oh, did he?
Signing off.
Okay.
I can see his hand. I don't know if
Oh, there it is. Okay. Dr. Mobley? For some reason my thing is not showing.
I don't see the doctor.
Yeah.
Did he get off? I wonder if he's on the other side. Up, let me move him over. Hold on.
That's why I didn't see him.
Sorry about that. I think you can come over now and speak. Sorry about that.
Oh, you're muted, Dr. Mobley.
I've been invisible for a little while, but let me add on to the last comment. Dementia Care Aware is wonderful for neurotypicals. That program is first rate. But it's very important to know that less than 5% of people with Down syndrome have access to a physician that knows really anything about Down syndrome. So even though Dementia Care Aware will be great for the largest portion of the population, those primary care professionals will not have learned about Down syndrome, will not have known anything about Down syndrome. So that population will still suffer from a lack of appropriate expertise around their care generally, and specifically with respect to diagnosing Alzheimer's disease and Down syndrome. As far as I know, there are only 2 clinics in California that routinely see such folks. There's ours at UC San Diego, and there's one at UC Irvine. I think it's a great, there's a real problem here. Most of the states doesn't know how to get their adult sibling or adult child with Down syndrome to a clinic where their problems can be properly evaluated and cared for.
That's a great add. Do you have question? Do you have a fellowship for this at UCSD? It's for
We
folks
don't
who
have a
might be
fellowship.
interested.
We don't have a fellowship, but we have a really good clinic, and Dr. Surya Lopez and I run the clinic, and we're in clinic we have a half day right now. We're seeing about 5 or 6 patients per day, and we're delighted to have new referrals. But just to let you know that we're now seeing people from outside California and from Northern California because of the lack of services that are available. We've asked audiences of parents of adults with Down syndrome how many people are feeling that they do not have proper access to care, and more than 90% of the hands go up. So this is a real issue, not just in California, but nationally.
Yeah. Well, thank you for what you're doing, and hopefully trainers would be able to shadow you there and learn more.
Happy to do it.
Great. Any other recommendations? If not,
I don't have a recommend. I don't have. This is Myra. I don't have.
Oh, hi, Myra.
Hi. But I would like to see if it's possible to get kind of a replay of today's project, because as people were speaking, they were speaking very quickly and sometimes not very loud. So I'm just asking if that can be possible.
We will definitely be posting the recording and the transcript and the PowerPoint slide. So you'll receive that in the next week or so.
Oh, terrific. Thank you so much.
Sure.
And it's great to see you, Susan.
You too.
All right.
I think that the work that we're doing here is just terrific. It's just really, really wonderful. So very glad to be a part of this.
We're glad you're here. So right now we'll cover some possible topics we'd like to address for next year. As some of the important topics we've discussed this year have been around wandering and emergency preparedness. So what topics should we discuss next year at these meetings?
This is Barbara. Well, I do think I'd love to get a kind of a report on the state of older adult behavioral health services with a focus on our families.
Susan will give us that update. All right. Anyone else?
Okay, well, there's another area that we haven't really talked about it much at all, or maybe at all. And I'll just put it out there. So the homelessness population, it's getting older, right? It just, the average age keeps increasing. And the research I've seen so far says that there's a growing percentage of that population that's living with a cognitive impairment. And the housing homelessness services world doesn't typically have embedded within it any expertise on older adults broadly, and even less on people living with a cognitive impairment. And I'm talking about like shelters that are specific for them, care plan. I mean, just anything. So they're just extremely vulnerable. So, I mean, that's just like a huge topic that I'm just kind of educating myself on as well, but I just put it out there as a possibility.
And I know one of the topics that perhaps we should consider, and I think we, based on the recent passing of the bill, is brain health itself. We've been talking about dementia, but how do we maintain our brain health? I think should be added for next year since part of the bill change, right? Anyone else? Let's see. Trying to see who has. Okay. All right. Well, you can always email us and give us ideas, but any final comment from the committee? Carol, you can put the last slide, I think, up.
Rosie, could you put the last slide up? Perfect. This is our 2025 meeting
There you
schedule.
go. So I think February 6th is supposed to be in person, right? For now. And so we have it May 1st, August 7th, November 6th. So pencil them in your calendar. There's no other final comment. Thank you, everyone, for your continued engagement. We look forward to your continued participation next year. We'll close the meeting.
Thank you very much.
Happy holidays,
you all.
everyone.
Yeah.
Thanks, everybody.
Thank you for coming.